Hi, Dr. Himanshu. Hi. I'm here, but I'll be active in half an hour. I'll just be there.
I prefer.
So,
You are here, but you are.
Good evening, everyone.
You joined for your talk, no?
We are live.
Oh, just 1 minute. A very good evening to one and all of you. Today, it's just one more very impressive array of talks put together for you with the top panel on the expert panel and the best set of speakers. And I'm so sure that once you switch on your Zoom, you're going to stay with us right through the 2.5-hour period. Don't miss out a single topic. We have on our expert panel, Dr. Rajesh Sinha, who is a professor of ophthalmology from RP Center, Cornea, Cataract and Refractive Surgery. And more importantly, he's also an honorary treasurer of AIOS and has done a great job in keeping the AIOS platform even more stable than it was over the years. Joining us would be Dr. Namrata Sharma, again, who's a professor of ophthalmology, cornea, cataract, and refractive surgery. And she's our honorary secretary. And we know through the COVID times what a major inroad she's made into improving the entire AIOS systems and putting things into place. We have with us joining soon Dr. Samad Vasak, the vice president of AIOS, and again, a senior consultant in cornea and eye banking from the Disha Eye Hospitals, Calcutta, and we look forward to learning a lot from him. Soon is huge experience in cornea and Dr. Sunita Chaurasia, who's again the consultant cornea and anterior segment and refractive and pediatric corneal services. And she's located at LV Prasad Eye Hospital, Hyderabad. And we really thank her for being with us during this very awe-inspiring webinar. And to take us forward along with me, I have this dynamic, handsome, prolific, smart, capable Dr. Himanshu Matalia, who is the superintendent of Narayan. And you can be very sure.
Is my network poor? Or?
No, I think we are losing out Chitra, and especially when she started talking about me, because I don't deserve those things. Let's get going. And we have our hostess, our beloved Dr. Chitra Ramamurthy, who has carved out the entire program very meticulously, and she's very passionate about the program. So be aware that if you guys are overshooting the time, she's going to hold you back and she's going to shake you that please stick to time. So looking forward to a wonderful discussion here. And we start with the first speaker, who is Dr. Soham Vasak. And Dr. Soham is going to talk to us about tips to achieve big bubble in deep anterior lamellar keratoplasty. Soham, over to you.
Thank you so much, sir. Let me get my slides up. Is it visible, sir?
Yeah. Absolutely. So it's visible and you're audible.
Right. A very good evening, everyone. And thank you at the outset. Thank you, Chitra Madam and ARC, for giving me a chance to talk on this forum. So I'll be talking about tips to achieving big bubble in DALK surgery. I have no financial interest in this talk. And in fact, we are actually celebrating 20 years since Anwar described it way back in 2002. What he says about achieving big bubble DALK, you do a partial thickness corneal trephination, then you insert a disposable needle with a bevel down and then inject air. What it then does is it separates the descent membrane from the overlying stroma. Then that is opened up and the stromal layers are removed. And then finally, we move ahead with the DALK procedure. So this is what he described in 2002. 2 decades later, the steps are pretty much the same, although with some refinements and modifications. So then the natural question arises, why bear the DM? Certain publications say that it gives the best visual outcomes. And there are contrary publications where it says that with suitable amount of manual dissection where you're going quite deep into the posterior stroma, the visual outcome is actually not different. And more importantly, we all surgeons feel that it gives a lot of excitement during surgery. So that's why you should always bear the DM whenever possible. Mechanism, the entire idea of doing a big bubble DALK is taking advantage of how the corneal stromal layers and collagen fibers are arranged. So difference between the anterior and posterior, central versus peripheral, and the presence taking advantage of the predesmatics layer. So these are the two types of bubbles that we encounter commonly. The one on your left is the type 1 bubble. It forms between the posterior stroma, and the blue, that is the predesmatic layer. The type 2 bubble forms between the predesmatic layer and the descemet membrane. Usually the type 1 bubble is slightly smaller, maybe 8 to 8.5 millimeters, less chance of perforation since you have got two layers here. It has got whitish margins and it forms from central to periphery. Type 2, if you're encountering, it's got a very high chance of perforation. It extends almost all the way to the limbus. It has got very clear margins and it starts from periphery and then expands. The ideal cases to do a big bubble DALK is basically keratoconus, except post hydrops. Then you can also do it in lattice or granular dystrophies. Less ideal would be macular dystrophies, deep stromal scars, and post-RK patients. Not ideal are the full thickness scars, previous history of perforation, or previous hydrops. Now, reaching the depth. What Anwar described is you go take out part of the stroma and go deep inside. So initially, to reach the depth, we do a partial trephination. So it can be done using guarded trephines, diamond blades. Now we have the femtosecond laser and also the intraoperative OCT. Or you can simply use the normal handheld trephines and go maybe 50 to 60% based on your surgical experience. Preoperatively, two investigations are most important. One is doing the pachymetry map, either a Scheimpflug or an anterior segment OCT. Second is getting an anterior segment OCT to ensure the DM integrity. If you have access to intra pachymetry, well and good. Now forming the bubble, I use a bent 26 gauge normal needle to do it. There are specialized cannulas, like you have the TANS cannula, the Fogler cannula, which is a blunt with a opening at the undersurface. Then there's the Sarnicola, etc. Then you have this instrument to make a tract for the needle and cannula. You need a 15 number blade or a side port to open the bubble. Corneal scissors, there are certain specialized scissors for cutting DALK, which sort of prevents injury to the underlying descements. And you have these TANS marginal dissector and the Fogler stromal dissector to easily sort of dissect the stroma. And now in this day and age, we have technology guided big bubble DALK. So either the femtosecond guided ones or the intraoperative guided OCT ones. There are publications in place which talk about how it is superior than doing it manually. Now the predictors, apart from the etiology, older age and more advanced cases of keratoconus is more likely to achieve a type 2. Type 2 again in places of deep stromal scar. Then females have a lower probability of achieving big bubble, and larger trephination size was associated with an increased probability of getting a big bubble DALK. And intraoperative factors between central and peripheral layer injection, there is no difference. Depth of the needle, usually 75 to 80% is good enough, where you are going 100 to 120 micron from the endothelium. Ideal IOP, too high intraoperative pressure, the bubble won't expand. And you can use a small double bubble for guiding your surgery. So these are the steps I'll be going over in the videos. So this is highly sped up. So first we are doing a anterior stromectomy. I'm doing sort of like a peripheral groove, and then the central part, just splitting it up using the crescent blade. So once this has been achieved, this is how you're left with. Then go deepen along the edges. So you have around maybe 75-80% depth. This is the 27 gauge needle bent at an angle. Slowly go in intrastromally. I prefer injecting the bubble from the paracentral area so that even if a perforation happens, it is maybe away from the central axis, and inject. And there you have a big bubble. Then you do a paracentesis, decompress the anterior chamber, followed by opening up of the big bubble, and then de-roofing it. In between, you can use a sort of iris spatula or any of the blunt dissectors to ensure that the stroma is completely separated. Otherwise, you can injure it while cutting it up with the scissors. This is just angular vanners that I'm using. I do not use any specialized instruments. And these are your regular Westcott scissors for sort of opening up each of these petals. And at the end of it, you have bare descent membrane, and you can proceed with doing the suturing. Now, if you have not achieved a bubble big enough, like in this case, the initial bubble is, after this, it is not expanding. So what you can do is take a side port blade and decompress. So you're lowering the intraocular pressure. And then when you inject, this will allow the descemetes to move backwards. So go in with a side port and make sure that you're releasing a lot of aqueous. So now and then continue with the air injection. So here you can see that the bubble slowly it expands than what it previously was. This is the brave slash opening. So you can use either a number 11 or a side port blade. That's how it is. And if you're lucky, the descemetes comes back slowly. Sometimes this does not happen. So you have to be very careful and move your blade away as quickly as possible. You can also aid it by putting viscoelastic on top. That sort of improves the visualization and also prevents a very rapid deflation of the bubble. And once that it has been opened, then you go in with a visco cannula and inflate it with viscoelastics before opening it up. So here you can see against the glow of the iris, you can make out where the brave slash has opened the posterior stroma. And what you're seeing underneath is the bare descemes membrane. Now coming to the concept of marginal dissection, sometimes the bubble might not form all the way in your trephined edges. So what you can do is, so here I'm trying to deflate and again sort of expand the bubble, but still this part, the superior part from 12 to 2 o'clock is, so at the end you just use a blunt dissector to separate the stromal fibers before cutting it open. Now complications. So first is, if you have not gone deep enough, you will not achieve a big bubble. So what you can do is you can try deeper and at a different site. So here I just getting some stromal emphysema. So I move in deeper and at a separate site. And you can try again to get it. So if you're not getting it still, then you can use a air visco bubble technique as described by Dr. Sarnikola, or convert to any of the manual dissection techniques. So then you can have mixed bubble or a type 2 bubble. So this is a case of macular dystrophy. Nice bubble initially. But when I am finally removing it, all the petals, you can see that there is a type 2 bubble formed underneath. Fortunately, that did not rupture. And this air in the interface will slowly go away with time. The second one is a case of keratoconus. And initially, here you can see this is a type 1 bubble which is forming. So before I realize it, it has already gone quite peripherally. So if you get a type 2 bubble, better to convert to a manual dissection technique. You can still attempt, but usually there is a very high chance of perforation. And this is exactly what happened in that case. So this is the same case. While removing the petals, unfortunately, I ended up with a perforation. And that DM just rips quite a lot. So very difficult to rescue. I had to convert to PK. This one again is a macular corneal dystrophy. So going in, so this one actually formed mixed bubble and then it ruptures into the anterior chamber. So bubble, and then now that you're seeing suddenly, that is actually bubbles which has gone in the anterior chamber. So again, this is something which you will have to convert to manual dissection. So finally, for successful big bubble DALK experience, choose the correct cases, have the ideal instruments, follow and master a single technique, ideally initially, and later you can learn the other techniques for as a backup. Judicious use of technology if available, and of course you should know when to convert to manual dissection, because always doing a DALK is better than doing a penetrating keratoplasty. Thank you very much.
Thank you. On to you, Dr. Himanshu.
Very nice, Som, and you made it so easy and so beautiful. Very nice. So I would bring in Dr. Basak here. This is very rare, where you can have father and son both on virtual dais, and it's heartwarming to welcome both of you. So, Dr. Basak, I remember you had presented in I think a few years back in Reshmi Award, those small bubbles which you expand, which you go deeper. Can you elaborate a little bit more? You're muted, Dr. Basak. You're muted. You're muted, Dr. Basak.
You have to unmute yourself.
Maximally done by my colleagues. So the concept was that if you identify the small bubble which is nearer to the DM, so you can use that small bubble. So intraoperatively, we put a pad up because we did not have any IOCT that time. Even now, we didn't have any IOCT. So you send the patient to ASOCT and take several scans. So you will find which bubble is more nearer to the DM and try to expand that bubble. So that was the concept done by my colleague and myself, and he was successful and he presented this in American Academy. That was a micro bubble expanded more to a big bubble. Here, Mustard is there, Rajesh is there, and
I'm going to come to him.
I mean, I am a big fan of Rajesh about.
I'm saving him for the last. Don't worry, I'm coming to him. So before that, I want Sunita to come in. Sunita, so many times it does happen in especially beginners' hands, or in fact, it has occurred in my hand many times, where you get such a big emphysema that you really don't know whether you have achieved a bubble or not. So how many times we should try, or we can try after debulking that? Or do you think the emphysema is too big, then it's better to convert to the manual dissection? How do we solve that?
I think the emphysema is usually we get only when we are very superficial. Your needle or whatever your cannula is superficial. So I think it's initially when you're injecting, it is good to just look at how the air bubble dynamics are going in the corneal plane. So if you see that it is going more towards the periphery and you're getting more of an emphysema, initial part I generally like to be a little bit slow because I want to see how the bubble is spreading out. So if it is going towards the periphery, I'll stop there because I know that I'm a little superficial. I need to go a little deeper. So going in the periphery is one sign that you are not in the right plane. You need to be a little deeper than where you are.
Okay, that's a good point. Dr. Rajesh Fogla, I think we all are a fan of you, and in fact, we all have learned from you this thing. So I've seen that many small things which you do, which has a reason, which many times we don't even understand. One such thing was you not decompressing the anterior chamber before. Can you tell us why do you do that, and what's the logic behind that?
Well, the thing is, experimental studies have shown that the size of the bubble has an inverse relationship to the intraocular pressure. That means if the pressure in the anterior chamber is higher, you will get a smaller size of type 1 bubble. And also, if you decompress the chamber before injecting air, the counter pressure is reduced, which means that when you get the type 1 bubble, you lose control over how the bubble is expanding. And sometimes you If you're using a 5 cc syringe with 3 cc of air, you may inject too much of air or the air is compressed in the syringe. So by the time you see the bubble forming and you decide to stop, the bubble can reach its maximal size and have a spontaneous rupture as well. So it needs a great deal of control when you decompress the chamber and you inject air. So by not decompressing, the advantage is that the aqueous acts as a counter pressure, so which prevents the bubble from enlarging too much. And also a type 2 bubble, if it forms, you don't know which area it's going to form, and it can go all the way to the periphery. If you have done a paracentesis before, you've already created a break in the DM. And if your type 2 bubble expands and it reaches the point of the paracentesis, then what will happen is the type 2 bubble will just rip open at that point of time.
Thank you. So nice of you. Dr. Chitra,
Shall we go on? Yeah. So our next speaker is going to be again Dr. Rajesh Fogla, and we don't even need to introduce him. He's such a famous personality and a national figure and an international one at that. And he's a director of the Corneal Services at Apollo Hospital, Hyderabad. And he's going to tell us something very intricate and important, tips and tricks to unroll the DMEK scroll. On to you, Dr. Rajesh.
Thank you, Dr. Chitra, for making me part of this program. I'll try and share some of the points regarding DM scroll unfolding. I have no financial interest to disclose. Currently, among the endothelial keratoplasty techniques, DMEK is becoming the most popular among corneal surgeons. So when you are inserting the DMEK scroll, the ideal way is that we want to see that the open end of the scroll, what you see here with the arrow, should be facing towards the surgeon, so that once the tissue is inserted into the eye, the open end of the scroll should be facing upwards and not down towards the iris. This ensures that the orientation of the scroll is maintained so that the endothelial side is facing out and the stromal surface is facing towards the surgeon. One of the things that happens when you insert the donor is that this is a fluid-based injection system. You inject the BSS, along with that, what happens is your chamber tip increases, the intraocular pressure rises. If your donor scroll has not yet gone in and now you push your donor scroll into the eye, if you have a leaky wound, sometimes there can be a partial or total expulsion of the donor disc. To avoid this, we try to release fluid from the side port, or we keep the eye or keep the anterior chamber shallow when we are putting the tip of the inserter into the eye. So once the donor scroll is injected into the eye, it can take any of these configurations. It can be a single scroll, simple fold, side down.
After this.
I'm audible?
Yes, you're audible.
Yes, Rajesh, please go ahead.
Yeah, so all these different configurations it can have. So this is a nice website called patientready.org by Peter Wellman, where he has described the techniques, videos, how to tackle each of these configurations. Now, typically, if you get a simple fold where you see the open end of the scroll is facing upwards, the trypan blue stain DM donor scroll, you can open it by tapping using 2 cannulas. You keep the chamber slightly shallow, secure the main wound, and then by creating these fluid waves, you can get the scroll to open up, and you have the S or the F stamp that tells you the orientation of the scroll, whether it's in the right configuration or not. And then once it is centered, well centered, you can inject an air bubble or 20% SF6 for the tamponade. If you have like a taco fold, you can try and inject some fluid to get the taco fold to move, to roll a bit, so that again, the open end of the scroll is facing upwards. And here you can see that the technique that we are using is basically peripheral tapping. So you try to tap in the periphery. As you press and let go, the fluid wave that moves outwards, it kind of unfolds the DM scroll. So now you can see that I've got a partial unfold. I move it to the center. With 1 cannula, I'm going to pin down the open end of the scroll. And with the other one, when I tap in the periphery, you can see that the scroll opens up. You can even release fluid from a side port in that quadrant as the fluid goes out, that can also help open up the scroll. So once you open up the scroll, you look for the stamp mark. Here you can see the F mark, which is in the right orientation. And then you can center it. And once it is well centered, you can go ahead, place an air bubble to secure the donor DM in place. It's always important that you watch where your cannula is. If your cannula is below the donor, it will turn blue. And here you can see that I'm trying to put another air bubble, but that air bubble has folded the graft. I take out the air bubble, and so make sure that don't do a wound assisted air injection. Always put your cannula below the DM scroll and then unfold it. The other thing that you can do is the carpet unrolling or the dedecember maneuver, where you hold one edge of the open end of the scroll, and with the other cannula, you tap, but on the inside of the scroll, not on the outside, and you can get the scroll to open up. And then you can see that you see the F stamp. You tap a little bit just to get so that the visual axis is kind of covered quite well. You see that there is an inferior PI as well, which is there to prevent the pupillary block. If you have a vitrectomized eye or a highly myopic eye with a deep anterior chamber, sometimes it's a bit challenging to open up the scroll because the chamber does not shallow. In that scenario, you can place a small air bubble on top of the scroll and use that air bubble to manipulate and open up the scroll. And once the scroll is opened up, you gently aspirate the bubble so that the donor DM does not go back into a scroll configuration, and then place an air bubble below to secure the graft. You can also do like what you have been doing in DSEC. You can do an endo-in technique where the DM is manually, you trifold it, then take it into load it into a injector cartridge, and using a micro forceps and AC maintainer to form the chamber, you can pull the graft into the eye. Here, the endothelium is on the inside, unlike the normal free-floating DM where the endothelium is always facing on the outside. This is useful where you have shallow chambers or you have presence of AC IOL. That's the same patient. You can see by day 7, the cornea looks pretty clear. This is another scenario where we are using the pull-through technique. So the DM is folded pretty much like a DSEC graft endo-in, and then using AC maintainer to keep the chamber formed, and using a micro forceps, the DM scroll is pulled into the eye. You don't let go of the DM scroll because the fluid movement from the AC maintainer can sometimes make the donor DM move around a bit in the anterior chamber. So I'm still holding on to the DM scroll, so I know that the orientation is maintained. And then using the other cannula to tap, I get the DM scroll to open up. And once it is opened up, I can place an air bubble below it. And I can, and you can see the F stamp here that tells you that the DM scroll is in the right orientation. So that's the same patient. You can see by day 5, the cornea looks very clear and the patient has 6/9 visual acuity. Out of all this configuration, the double scroll configuration is the most ideal. So while we were doing our surgeries, we realized that there is a maneuver whereby you can get the DM to scroll into a double scroll, which we published last year in Cornea. So what you do basically is after you have aspirated the DM scroll into the wider part of the glass injector, you can agitate the fluid. You can basically pull the DM scroll into the narrow part and again push it back into the wider part. So when you push it from the narrow to the wider part, what happens is the scroll opens up, and then when it re-scrolls, it can go into a double scroll configuration. In about 20 eyes that we looked at, we found that this could be achieved in almost 85% of the eyes. In very older donors where the tissue is not very elastic, this may be a little bit difficult to achieve. And also on the converse side, if you have a very young donor where it forms like a cigar roll, it may be a little challenging to get the double scroll configuration. So the second thing that we wanted to know is how to prevent the tissue from trying to jump out of the eye. So we thought about doing a unidirectional flow. So we connect the AC maintainer, get the flow on, insert the tip of the inserter into the eye. Then we rotate the tip so that the open end of the DM scroll is facing upwards, following which we ask the nurse to stop the flow in the ACM and also disconnect the anterior chamber maintainer from the IV tubing. And you will see that now when you insert the DM scroll and you are removing the tip of your cartridge, there is no tendency for the scroll to jump out of the eye. And since the fluid leaks out from the AC maintainer, the chamber is also shallow. And this helps maintain the double scroll configuration. Once you have a double scroll configuration, the unfolding of the DM scroll is reasonably simple, and you can do that pretty easily. As you see in this is basically an unedited video showing the DM unscrolling in real time. So basically you can hold the graft on one side, and the other side, either you release fluid or you can just do peripheral tapping, and that can open up the scroll, following which you can place an air bubble below. And the overall time duration is less than, about 2 to 3 minutes, you can get this scroll to open. And this, you can see that it's quite repeatable. And this is what I do here. I don't have a double scroll, it's a single scroll. We look at the open end of the scroll, and as we insert it into the eye, you can see that as you are withdrawing, there is no tendency for the scroll to jump out of the eye. And then you can tap on the center to get the scroll to open up on one side. And once it is open on one side, you can just press to secure that. And then this is the Dirisamer maneuver, and your scroll opens up, and well centered, you can go below and place an air bubble to secure the graft. And this is fairly reproducible that we have seen. So what the game changer has been is the marking using the S or the F stamp through a stromal window, or you can make this triangular notch in the periphery where the notch or the arrowhead is going in a clockwise direction, or you can put asymmetric 1 and 2 marks, which again, when you join them, they go in a clockwise direction. So these are ways and means whereby it makes life easier for the DMEK surgeon and not have sleepless night thinking that I have put the graft upside down. And the other thing that we do nowadays, we prefer to do is to use an air bubble over the fold of DM to mark, rather than making that 3 millimeter stromal punch. So you can see that we have partially stripped the DM, after which we use a 30 gauge cannula and place a air bubble within the fold of DM. You dry off a little bit of the excess fluid, and then you can use your Sinskey hook and you can create your F stamp very easily on this folded DM. So what happens is the rest of the stromal tissue is intact, and if you wanted to use the rest of the stroma for a DALK, it can easily be used. Other ways of identifying orientation is to use a handheld slit lamp, or the best way is to have intra-op OCT, where in real time you can see the orientation of the DM scroll. So these are, in short, the tips and tricks that can help you perform a DMEK surgery much more easily. And I think as a surgeon goes on with the surgery, every individual surgery is a learning experience. And I think you should watch videos looking at all different configurations, because it's not necessary that always you will have only one type of configuration when you insert your donor into the eye. But if you know all the different tips and tricks, it will be nice to atraumatically unfold the graft and minimize the endothelial cell loss in DMEK surgery.
That was an amazing talk, Dr. Rajesh. Amazing. So simple, you made it all appear. Dr. Rajesh, would you want to add anything else? I doubt whether there was anything left unsaid. Would you like to add anything on this?
You mean me?
Yeah.
Yeah. Actually, it's a very wrong time that you have asked me, Dr. Chitra, to add something, because, we added once Dr. Fogla has spoken about DMEK procedure. So I was just spellbound and I was watching his videos. That was fantastic.
Rajesh, one thing I can ask you, that with intra-op OCT, where you have access to that, how easy it becomes to identify if the scroll is, especially when you're not sure about the stamping, or the scroll is not clearly visible. How often do you prefer to keep the OCT on, or you continuously keep it on? Practically,
actually, intraoperative OCT definitely helps us to know which way is the scroll, and that is also particularly helpful when you have a slightly more edematous cornea, a little hazy cornea. In such a case, it is really helpful. Most of the times, the stamping is quite effective and it helps, but sometimes the stamp is not that clear, it's not that prominent. In such cases, intraoperative OCT is really useful to exactly know which way the curl is. So, I mean, it is helpful. It has an additive value, particularly in slightly hazy cornea.
Sure. Thank you. Dr. Basak, which are the donor which are like sort of red mark for you or red flag for you that any particular age, any particular disease, any particular pair of donor, what makes you think that, you know what, this is not the most ideal donor which I would select?
So for ideally, the learner should start with the tissue of age between 55 to 65 or 70, that way. And for donor preparation, also non-diabetic, severely diabetic renal failure patient. Recently, I had experience, but not that which are reported, because you will learn the trick how will you rescue those small tear. But initially, you should avoid those tissue for donor preparation. For unfolding, when you learn the technique, you can, the best tissue is between 55 to 60, but I have used a series of patients more than 80 years, and I am still using it. Those are basically flat DM. There is no scroll formation. Sometimes you are surprised that I have video, it takes only 10 seconds to, you see that whole DM is open and it is in right direction, 10 seconds. So, but sometimes it may be reverse, but you can always flip it. I usually, my preference, if the cornea is hazy or you find difficulty in like deep anterior chamber, high myope case, I try to pick up older donor, because I know that unscrolling in this group of patient is difficult, because there is always a tendency to reform the IC, especially with vitrectomized eyes. You open it, you come out, and again AC deepen and your scroll is again reforming. In this group of patient, if you use little older donor, say 70, 75, something like that, then the DM, it is not a scroll, it is a flat type of a half scroll or 1/4 scroll, something like that. Then you can easily unscroll it total flat. And once the orientation is right, I find those are easy. And regarding younger donor, you can, prepare the graft. I have prepared lowest stage is 27, but unfolding is really an issue. And donor preparation is also an issue. But by and large, between 45 to up to 90, if your cell is good and morphology is all right, you can always use those tissue.
One question to Sunita. Sunita, which are the cases where you would be careful in terms when you take them up for the surgery? Which are those cases where you may find that there can be fibrin inside, or there can be things which you sort of preempt that as a beginner we can avoid such kind of cases? Which are the not so ideal cases which we should be avoiding in the beginning?
I think pre-operative planning wise, one should really look at what is the status of the IOL iris stability. And quite often majority of our cases like Fuchs are, because the primary indications will be a good indication, but those cases which have had a PBK and where the iris is distorted, pupil does not dilate, those are the cases which are bound to even have vitreous in the anterior chamber in the course of management. So those are cases. And diabetic patients, sometimes you can just reckon that their iris is very, very different. Particularly if it's a combined surgery, sometimes the pupils don't dilate. These are some cases which I would say where you can have these kind of eventualities where you deal with fibrin, vitreous in the AC, which makes unfolding little challenging.
Can I just add one thing?
Please, Rajesh.
Actually, in a couple of cases, what we have found out that while doing PI, there was some bleed. And then in that case, I guess we need to put air and wait for a longer period so that the bleed stops completely. Otherwise, if there's any blood left, then it really causes that fibrinous strands. And many times it is a major reason for detaching the Lenticule.
Dr. Fogla, one last question to you. Is there any effect of storage, duration of storage of the tissue on the way it behaves, the way it unfolds, or way it peels from the surface? So, older tissue, I mean, the duration of storage I'm talking.
I have not found the duration of storage to affect the donor preparation. I think it's more like the older age can be more friable. You know, sometimes you have tissues that tend to pinch off in the periphery when you're trying to peel. And like Dr. Vasak said, that some of these diabetics, they have abnormal adhesion. So if you start peeling from the periphery and you feel that it's not going the right way, instead of damaging the entire tissue, maybe think of doing a rescue by doing a dissect using the same tissue, you know, rather than going all around and getting tears everywhere.
Exactly.
Because you can make it out right in the beginning. It will start just peeling from the periphery about 20%, and then you find that you get this horseshoe tears, and there are these, like, I usually, when I peel, I don't hold the sclera. I don't hold the rim. I just leave the tissue in the punch, and I'm just peeling with one forceps. That ensures that I don't have too much of pressure when I'm trying to peel.
Is your vacuum on that time?
No, the vacuum is not on. I just ensure that there is no fluid under the cornea. So the tissue doesn't slide. So that gives me optimal idea as you're peeling. If your tissue starts moving a lot, that means there is abnormal adhesion. If you keep holding with your left hand the tissue, obviously the amount of pressure that you're going to apply will be significantly more.
And one thing I want to add that we are using a lot of MK medium preserved tissue. So it is 50-50 like. So both are good. There is nothing wrong with MK medium because we are using on day 3 on those corneas. So we can check, all the quality check has been done, nothing is. So we use MK medium preserved tissue. And by feeling, and we have also, though not statistically significant, we have compared the data of both MK medium and non-corneal preserved. MK medium preserved tissue, the peeling is easier feeling.
I'll agree on that. I think it's just because
easier feeling that I feel that it is easy. And time-wise, less than corneal, not statistically significant.
Thank you. I think we can keep on talking to you all, and there's no. Yeah, please, Rajesh.
Yeah,
please.
Cortisol, you need to wash it off because it's a little slimy. So you don't use the cortisol.
Yes.
What happens is sometimes you find that even to hold the tissue and peel. So if you just wash off the donor storage medium, then it becomes a little bit easier. But like you mentioned, MK medium tissues are a little thicker, swollen. So that's why maybe you feel that the peeling is a little easier compared to cortisol.
Thank you, Dr. Rajesh. Please stay connected. We need to learn a lot from you during the course of this webinar. We shall now go on to our next speaker, Dr. Praful Kumar, who is going to tell us the different techniques to manage corneal perforations. On to you, doctor. Dr. Praful is the senior consultant from RP Center and would tell us which is better, the adhesive tissue, the Tenon's patch, or the conjunctival flap.
Praful, you are muted just to...
Yeah, unmute yourself.
Okay, if my slides are visible?
Yes.
Yes, slides are visible, you're audible.
Thank you. So the topic is a little bit lengthy, comparing whether to use cyanoacrylate glue or Tenon's or conjunctival flap. So Tenon's patch graft, it has been described for corneal perforation, small as well as large, scleral melting as well as neurotrophic ulcer. My experience is largely with corneal perforation and corneal fistula. So corneal fistula, I hope you all know that, as you can see on the left, although it appears apparently healed, but when you stain it, you will see there are some leak. Okay, so these are the cases initially when I did Tenon's patch graft. And this is a microscope into the OCT picture. You can see there is a track which is all the epithelial lines, but still there is a communication to enter a chamber. So this is a video. Normally we do such cases in emergency. So sorry about the quality of video, but you can see there is a leak and the perforation is almost 2 by 2 mm size. So first you have to measure the size of the defect and then measure and take either supratemporal or supranasal quadrant and do a peritomy and try to separate the tenons tissue both from the conjunctiva as well as the underlying epicleral tissue. So it's not a very difficult procedure. Easily you can do that. If you have done ECC or any conjunctival surgery, then it won't be that difficult for you. So idea is to take little bit oversized graft as compared to the size of the defect. And those who have done tenons, they must corroborate with this. Tenons tissue, it has basically two parts. One is little bit more fibrotic surface, and then there is a more like fibrofatty tissue. So you have to trim that fibrofatty tissue, and you have to orient your graft in such a manner that the fibrotic component is anterior. And one easy way to identify that, you can stain the tenons capsule. It usually the anterior fibrotic part takes the stain, but not the fatty tissue. And you can create 360-degree lamellar pocket all around the defect so that the grafts tuck in well. And suturing, you can do any sort of suturing. I have seen a lot of modification of this technique. So I prefer interrupted suture because that allows me to adjust any complication post-operatively. And you must bury all the suture. If you couldn't bury and it's an acutely inflamed eye, you can simply put a BCL over that also. So this is just a picture of such cases. You can see there was a free communication, and this is a picture showing tenons patch covering that fistulous tract. So we published a series of 6 cases in BGO. Subsequently, Dr. Namda came out with this paper, including 31 cases of tenons patch graft. The outcome is usually good, but you can see the few problems with tenons patches. Somehow there are few vessels, superficial vessels, they come up, and could be due to some intense inflammation post-operatively. And sutures, you have to remove the sutures post-operatively, which is maybe difficult in such cases. And as you can see, vascularization is there. And however, but you can see this was a little bit large neurotrophic ulcer. Well, it healed quite nicely, got epithelial line. You can see the tenons tissue here. This is a picture sent to me by one of my fellow, where she had no access to patch graft or corneal tissue. So she did a tenons patch in such a big ulcer, and it healed quite well. So limitations, as I've said, it's an opaque tissue. So if you are doing it in a central corneal perforation, the patient is not going to be rehabilitated visually. You have to do a secondary graft. It doesn't have any tectonic support, as you would have noticed during that video. Cyanoacrylate glue gives you some tectonic support, but tenons patch is not going to give you that. If you are doing it in a large perforation, you have to supplement it with glue. Leak, I'll just show you a video about that. Yes, sutures are a big problem because it's an acutely inflamed eye. You have to do a second procedure to remove all the sutures. And yes, it induces vascularization, not as severe as cyanoacrylate glue, but yes, it do induce some vascularization. This is a patient where next day there was a leak. You can see it retracted. The graft didn't have any tectonic strength, and it was a little bit bigger size perforation, and it was leaking from all around. So in all these cases, tenons has to be supplemented with some cyanoacrylate glue. So advantages, yes, it offers you an alternative, especially when you don't have an eye bank setup and you don't have AMG or donor cornea with you. Cost effective, although cyanoacrylate glue cost you hardly 1,000 odd rupees, but there will be still some patient that they can't afford even that much money. And at times you are sitting in casualty, in midnight somebody comes with perforation and you don't have access to glue, then at that time also tenons patch can help you. Glue with BCL, yes, there are 2 variants, biological, the fibrin glue that we commonly use, and the other one is cyanoacrylate glue. And I think most of us would agree that for corneal perforation, usually we prefer cyanoacrylate glue only. Why? Because it's a very fast procedure, the cost is less, and the most important is gives you tectonic support. So you can do it in office as an office procedure in the slit lamp, or you can take the patient to microscope and do it under sterile precautions. This is a short video about that. This is the cyanoacrylate glue, histacryl glue that at RP Center we have this. So this was a case of descemetocele, as you can see. So important trick is you have to debride the epithelium surrounding the area of your perforation or the descemetocele. And people prefer to use some needle and put it through a 30 gauge or 23 gauge needle. But my preferred procedure is this: take any blunt instrument, just touch the glue and just touch it to the surface of your interest. This allows you to apply a very thin layer of glue, because one of the problem with glue is it forms a, if you apply it too much, then it will cause a lot of surface irritation, and there could be GPC, and even it is difficult to place the BCL also. So allow it for some time, and after that you can do a thorough wash. But this was a simple case. At times when you are dealing with perforation cases, you have to do a interchamber paracentesis, and you have to inject air, or rarely maybe viscoelastic to form the interchamber. But most of the time, the result with cyanoacrylate glue is quite satisfying when the perforation size is less than 2 mm. There have been other technique, people have described other technique, like this was the needle based technique. But one clue is when you are using this, retract the plunger little bit once a blob is formed. But this will allow you to apply very little amount of glue onto the surface. The other commonly used technique is patch technique. In this technique, you can take a dermatological or skin trephine of 2 mm size and take multiple sections of your sterile drape, and using any blunt instrument, you can apply some ointment over that and pick these small patches. This patch technique is usually useful when the ulcer sizes or perforation size is a little bit larger. And this ointment allows you to pick these small patches. Pick any one of them and just apply some cyanoacrylate glue to the surface. And this will allow you to just patch it over the area of defect. So this allows you to apply a controlled amount of glue with the patch. The problem, the other advantages of cyanoacrylate glue compared to your tenons is it has some effect on preventing stromal melting, and also some bacteriostatic effect for organisms like staph, E. coli, and Pseudomonas aeruginosa. So these are few example of post-op pictures of glue BCL. This was a post CXL keratitis patient, which healed well, but you must notice this vascularization that is there. This is the surface magnified picture of a surface of a glue. See, the glue, no matter how much the thin layer you apply, the surface is always irregular. And by chance, if your BCL dislocates, then it's very likely that the patient will develop some papillary conjunctivitis. This is a patient which healed, but you see the amount of vascularization that the glue has induced. Because at times there may be some active infection and you may not be able to give steroid post-operatively. Patch graft, yes, if the size of perforation is large, you have to do a patch graft. And in that case, all the complication of cornea transplant will be there. Conjunctival flap, I'm not a fan of this technique. This is the picture from Sun et al. Recently published paper where they use this partial selective peduncular flap, where the conjunctival graft is mobilized and advanced to the site of perforation after putting a layer of AMG. Conjunctival flap, then you may find few big fans of this technique, but usually this technique has some severe problems, like it completely obscures the view. You cannot see what is going on behind the conjunctival flap. And it's an all or none operation, because since you have advanced the conjunctiva, you don't have a second chance to correct it if anything goes wrong. Lastly, since most of this patient requires some secondary corneal transplant for visual rehabilitation, conjunctival graft, they induce a lot of vascularization. So it's not a good idea if you're planning to rehabilitate the patient using optical PKP later on. So this is the review article that I published along with my team, surgical alternatives to keratoplasty in microval keratitis. Here we had discussed all the available techniques, not only these three, but the other techniques like tarsorrhaphy or fibrin glue, corneal patch graft. I have taken the section of the table that suggests this, thus compare these three techniques. As you can see, the healing rate is almost same, and even conjunctival flap, the healing rate of 80 to 95% has been reported. But the main problem with tissue adhesive is they induce corneal vascularization and the foreign body reaction associated with that. With Tinan's patch, although it's a good technique, but the tensile strength is almost nil. So you have to supplement with some cyanoacrylate glue. Conjunctival flap, it's good. If the patient doesn't have any visual potential, you can go ahead with this. But the problem is, even in those cases, cosmesis will be a big issue. So when and where to use this technique, it depends on availability. If all the three are available and the size of perforation is less than 2 mm, I would prefer to go for TABCL, tissue adhesive. Why? It is very simple and quite effective. If it's not available, I would prefer to go for Tenon's patch rather than a conjunctival flap. Tectonic strength, if a person is little bit on larger side, you cannot do Tenon's patch or conjunctival flap. You have to supplement them with glue only. Cost-wise, yes, Tenon's and conjunctiva, these are autologous tissues, so they don't increase cost in any way. But TABCL, yes, it do cost some amount of money for the patient. Future graft, if you're planning to rehabilitate the patient using a keratoplasty subsequently, it's always too good to go for a autologous tissue like Tenon's patch or multi-rad AMG, which was not a part of my topic. So this is it. If the corneal perforation is small, go for a TABCL. But if you don't have that access to that, go for any of the procedure. If it is little bit large, Tenon's is preferred, but you may have to supplement with some tectonic support like cyanoacrylate glue. But the most important point is whenever you are dealing with such cases, because all these cases present to you in maybe in emergency OR, you have to close it. You use a BCL, use a AMG, whatever is available with you, you can use that, but please close the link. Thank you very much for the kind attention, and thank you, Chitra ma'am, for allowing me to speak on this platform.
Thank you, Dr. Praful. That was a very thorough, detailed talk. I would take two simple questions with Dr. Nikhil before Himanshu takes on again. Keeping aside the cost part of it, Dr. Nikhil, you're there?
Yeah, he's there.
Yeah,
He's there.
I'm here. Yeah.
If cost is not an issue,
Yeah.
for very small perforations, would anybody think of using a fibrin glue, or it's only a cyanoacrylate? And in case of active inflammations like peripheral PUK, how would you deal with those perforations? Would you temporarily use stenons, or would you use active immunosuppression and use a tissue graft?
Yeah, so if you have a PUK, of course, we need to use systemic treatment to quieten the eye before we do any patch graft or corneal graft. But before we do that, for a temporary measure, one could do a conjunctival resection, glue BCL sort of procedure, and it can help us to buy time. But sometimes, the patient lands to us with a big perforation with iris prolapse with a PUK. And at that point of time, in such instances, we can give IV methylprednisolone and do a patch graft and then supplement it with post-operatively with the help of the rheumatologist, because there you don't have much of an option, or, you cannot immunosuppress before you do a definitive surgery. So it depends on the situation, although we always prefer to first control the pathology and then treat it. But in situations which are demanding, you may have to do them simultaneously. As regards the TCL glue or these fibrin glue, sometimes you can use them along with the Tenon's patch graft. So as Dr. Praful was showing us, so once you put the Tenon's patch graft, you can put a thin layer of the TCL on that. Or if you're using an AMG, maybe 2 layers of AMG, you can put the TCL glue to secure it. Just the TCL glue, maybe in extremely tiny thinning areas or something like that, or sterile melts or something like that, one could try, but and put a bandage lens. But then again, if there is tissue loss, it will not have that tectonic holding strength, I think.
Yeah. I have a question for Praful. Praful, in the presence of infection, what would be your take on Tenon's graft? If there is an active infection, if there's a case of microbial keratitis which has perforated and the perforation is not large, would you like to put the Tenon's patch?
As I said, I prefer Tenon's in a little bit quiet eye. That's why my report was in cases with corneal fistula, but there was no infiltrate, because passing suture is a little bit difficult in presence of necrotic tissue. So if active infection is there, perforation is small, as I said, TABCL should be the preferred choice, because not only it gives you that support, and also it has some bacteriostatic property, which may not be that useful, but still, as far as compared to Tenon's, is that TABCL should be the preferred one.
What about resolving microbial keratitis?
If you think the margin of the ulcer are not that necrotic or not that edematous, to avoid you putting sutures, because Tenon's, there have been report people have used only fibrin glue to use Tenon's patch graft, but I don't think it will stick if the perforation is relatively large and there is active edema, active infiltrate is there. So if you can pass suture, you can go ahead with tenons. If you feel suturing won't be possible in those cases, maybe tenons plus glue BCL is a better option.
So I think
Apply
that
tenons
needs
patch,
to,
put glue BCL glue
yeah,
over.
that needs to be clarified, I think. Okay.
Okay, Praful, I have one simple question. What's the fate of tenon? What happens to the tenon if you do an OCT or something?
Yeah. It gets epithelialized, but I said it's opaque. That area will be white only.
Okay, so when you have a tenon which is not tucked in, how easy or how difficult it is to get epithelialized that? So is that the reason where you said that you should tuck in the tenon and putting on the surface does not help you to epithelialize it as fast as when you tuck in the tenon when it happens?
If you are not doing the tuck-in part, then epithelialization not only delayed, in few cases, we had to redo the surgery because epithelialization never happened in those cases. So that's why it's good to create a pocket and ensure that the tenons is below the epithelium. And if you feel that your apposition is not well, it's better to put in BCL.
Thank you. One last question to Dr. Nikhil. Dr. Nikhil, what is the longevity of cyanoacrylate glue? How long it stays, and what do you do if it stays longer than what you need? Do you remove it? Because sometimes if it is a perforation which is sort of holding on, does it actually open up, or do you open it in OPD? Do you open it in OT? What do you do? How do you deal with such kind of cases?
So we need to understand that it heals with vascularization. So depending on the location of the perforation, the time required for healing with a glue BCL will be different. For example, if you have glued a central perforation in an avascular cornea, for example, let's say sterile melt or something like that, it will take a pretty long time for the vessels to reach there and for the healing to happen. So the amount of time the glue should stay will basically be indicated by vessels around and even in front of the glued area. So all around the glue, once you see vascularization, it indicates that there is a healing process is going on, and then probably you can consider removing the glue, and the glue itself starts getting loose, just like a scab falls off following any wound injury. So typically it may be 3 months, as long as 3 months for more central lesions. In the peripheral cornea or in vascularized corneas, they would heal much faster and you can remove them faster. Actually, if you're confident, you can easily remove them even in the OPD. If the glue is loose or it's already sometimes, just moving around. The only thing is that if while removing the glue, one has to be careful that you don't exert traction on the thin area. Otherwise, it can sometimes create a new perforation and you might have to re-glue it. And of course, if you don't have vascularization, then sometimes the glue, once you remove the glue, there is again a hole there. So that can be a rare instance which can happen, The other thing I wanted to also mention is that when I definitely see a good number of sterile melts, which may be autoimmune in origin. And originally, as a fellow, I probably was very happy gluing them. But I've realized that they cause so much of scarring and vessel formation that now I tend to do more of patch grafts or small grafts, which may be 4 millimeters or 4.5 millimeters in size. Sometimes they might be abutting just close to the optical axis also, or at the edge of the pupil. But in the long term, they're avascular. They hold well tectonically, and the patient has much better outcomes. And even if you need to do a penetrating or a graft later, it has much better success rate because the vessels are not there. Whereas once you do glue, it's like a deep vascularization with scarring, and it makes things as a high risk.
Thank you. So nice.
Dr. Himanshu, can I add just one thing?
Sure, Praful. That's the last comment from your side.
If glue is there for a long time, and it's very common at our setup, what I do is I try to move it a little bit on SLET lab. If it moves freely, most likely the underlying area is well epithelialized. But if it is not moving freely, then it's better to take the patient to OR and keep another set of glue, fresh glue ready with you. So the moment you take it out, it may start leaking. So this is...
That's a wonderful point. I think we'll move it.
Should be, Dr. Himanshu, since Raksha is not there, do we discuss anything on
I
ocular?
think we'll go ahead because we have too many speakers and we have very interesting topics there. So I think we'll move on. We'll go with Dr. Ashish Nagpal. He's there. So we'll start with.
We have with us Dr. Ashish, who's again a medical director and chief surgeon at Nagpal Eye Center for Cornea and Laser Center at Ahmedabad. And he's going to talk to us on another important topic, PTK versus ALK for corneal scars. On to you, Dr. Ashish. You may have to unmute yourself.
Sorry.
What's happened?
Are my slides visible?
Yeah, they are visible.
Yes, slides are visible and you're audible, Ashish.
Okay. Thank you so much, Chitra ma'am, for having me in this beautiful session, things with such senior speakers and faculty. I'll try my best to cover in the next few minutes a little bit about corneal scar treatment. I'm having some trouble with the slide.
Yeah.
Just reshare it again.
I don't. Mr. Sunil, could you help?
Yeah. Just click on the screen, sir. You should be good to go. Just click on the screen. It's coming.
It's working now. Okay. So I think we all, as corneal surgeons, we all have to deal with corneal scars after treating all the infections. And I think it forms a huge component of corneal blindness. And we do try and treat them with various options. I think in this session, so what do we have to treat corneal scars? I think we definitely have a full thickness keratoplasty, as we've all been doing since many years. And now, since a long time, we have lamellar keratoplasty, also called as deep lamellar keratoplasty, in which we can replace the anterior layers. And of course, if there are superficial scars, we can do a laser PTK. So for this session, we'll be dealing with the lamellar options and the laser PTK, and just have a brief overview of how we can go about treating them. So suppose you have a corneal scar and it is impeding the vision, like this scar, as you can see over here, or you may also have some degenerations which may lead to scarring, or it could be dystrophies also which lead to recurrent epithelial breakdowns and infections. So I think the most important thing is deciding how we will be able to help the patient, whether the patient needs it, because sometimes the other eye is functional and a lot of patients do well with just contact lenses, because it may just be some irregularity of the anterior surface. Once we have gone through that procedure of checking the best corrected visual acuity with the non-surgical options, we can look at the scar in detail, the location, and the depth of the scar, which is important. Nowadays, we also do OCT. We are easily able to see the depth of the scar, which earlier used to be difficult. And with these options, one can decide the treatment protocol. So now for the PTK, I think the most important thing is that we need to limit ourselves to the 100 microns or so. Because if we go deeper, it will lead to more ablation of the tissue, and it may cause other problems, which I'll discuss in the next few slides. So what are the few tips? I think this is a very nice flow chart, which I found in the IGO. And I think when you're treating a scar, it's important to look at the epithelium. Because how the laser will ablate is very important. It's a little tricky to understand. This is another cartoon which explains the same. So if you have an irregular epithelium and if you do the PTK, it will replicate the same it will mirror the same irregularity in the stroma as well, below the Bowman's. And that again will, the epithelium will have to mask. So how can we reduce it if it is beyond the scope of the epithelium to cover it? So nowadays we have access to trans-PRK or trans-epithelial ablation, in which the epithelium itself acts as a masking agent. Otherwise, one would need to debride the epithelium and then do the PTK. And I think most people do debride it as they do for PRKs. So this is just to show an example of, this is a case of a granular dystrophy in which we did a PTK, and you can see this is in the early few weeks when you can still see the epithelium healing and the demarcation. So in these situations, you tend to take smaller optical zones as well, which are fine because you're trying to clear the central area. So the important thing here is to keep in mind that you will be inducing hyperopia, which needs to be discussed with the patient. There are some ways in which you can roughly calculate what to expect. Nowadays, with certain lasers, if you have access, one can still do some modulations in the periphery to decrease this hyperopic induction. And of course, we also have access to mitomycin C, which is usually used by many surgeons and also not used by many. So I think I'll leave this discussion for later, whether to use it with the PTK or not. So this is just an example in which this is a patient of granular dystrophy in which you can see the central clearing, and the patient has been following with us up for the last 6-7 years, and fortunately it has not recurred, although there are a few crumb-like deposits in the center which are not impeding his vision. So more or less for most corneal scars which are limited, in which we would do a PTK, these would be just the thumb rules to go by it. But then there are scars which may be deeper. Sorry, I think with just a few, one slide which I just made to keep in mind for PTK, the cons. One is the recurrence of disease based on the pathology. If it's a dystrophy, more likely to recur. We have to keep in mind herpes simplex. If your scar was due to an HSV keratitis, one needs to take care to give prophylactic antivirals and also maybe follow up the patient for longer. Refractive error I have already discussed, and of course if you over ablate. So suppose if you look at the pachymetry, the general FDA approval is up to 250 microns, but it is, as a standard practice, we recommend that we should keep at least 300 microns of the residual stroma. Otherwise, corneal ectasia also has been reported in these cases. So coming to the deeper scars. So as I discussed with PTK, we are limited to the anterior 100 microns, and it gives very good results. It's non-invasive procedure, non-surgical, no sutures, nothing. With the DALK, we can solve many problems of deeper scars, but then you have to, if the visual recovery is longer, it does have all the complications which are suture related, although it does have good results as well for deep pathologies. So these are the options available. One can call it a superficial antilamellar keratoplasty, which may be limited to the anterior 250, some say to up to 350 microns. The other option is a hemi-anterior lamellar keratoplasty, and the third is a femtosecond. So I think I've briefly collected from a few colleagues and friends some 1 or 2 cases of SALK and a femtosecond assisted, and I'll briefly take you through them. So this is a case of a 38-year-old male with a resolved fungal keratitis and with a central scar involving the pupillary area, as you can see in both the slit. So it's very important to look at the slit lamp. I think however much we underestimate, the slit lamp examination would be the key to decide what to do. And of course, in this case, the OCT will guide us up to the depth. So how is it done? In this case, this is a modified microkeratome-based superficial anterior lamellar keratoplasty, in which a keratome, a basic LASIK keratome, and a kind of a LASIK flap was made by the surgeon with a deep flap of around 300 to 350 microns. And as you can see, in skillful hands, even one can dissect this LASIK flap and create a free flap out of it. And you can see the underlying bed is fairly clear. There is a slight faint scar, if you can make out, is still over there. So once this is done, one can repeat the same on the donor cornea and put it in the medium and then just place it over the recipient. The advantage of a SALC is that it's a sutureless procedure. You really don't need to take any sutures, but you need to take precautions just like you would in a LASIK flap, or sort of if you get a free cap, sometimes what you would take care to make sure it's well aligned, it's well oriented, there are no striae, you make sure there are no interface irregularities, and then put a bandage contact lens. And you can see this is an outcome after almost 2 to 3 months, and the patient had improved visual acuity to almost 6/12 in this case. So this is a way of doing an anterior lamellar keratoplasty with the help of a microkeratome. But there are other instrumentations available in which you do not need to, which make a free flap by itself. So there are ALTK instrumentations available with Moria and other companies. But the only problem sometimes which does occur is a slight mismatch in the size or a mismatch in the shape. And sometimes it may induce astigmatism. And sometimes the orientation, the shape of this microkeratome boost lenticule, as we know, is always meniscus based. So that may also lead to some changes in the shape of the final outcome. So that's where I think the femtosecond, which is far more precise tool available to corneal surgeons, has come handy. I'll just briefly start off with the video from Dr. Sharon D'Souza at Naran Netralaya, in which you can see this is the femtosecond in which they are trying to create almost a 250 micron deep donor lenticule, which is mounted on an artificial anterior chamber. The docking is very similar to as you would do for LASIK, and then you start the femtosecond and it creates a flap of the exact same, the precision is better and it creates a full 360-degree flap. And in this case, again, a healed corneal scar, healed keratitis. The only problem with femtosecond in certain situations is that if it's a very dense scar, then sometimes the femtosecond may not be able to penetrate the opacity as well, and there may be some tags left behind or attachments. So that has to be assessed, and nowadays with the help of good anterior segment OCT systems, it's possible to predict. In fact, they also use it to create better flaps. And the rest of the procedure is, I would say, very similar to LASIK, or femto-LASIK, and nowadays quite a few of you must be smile surgeons as well. So that would be very simple. And you can just lift the flap and place it onto the recipient. And again, with all the due precautions, you put a BCL. So this is the basic procedure. This is the slide showing, you can see the attachment of the flap on the first post-operative day. And one of the studies also had been presented from Naran Netralaya, and it did show good outcomes. Although the basic problem sometimes is that one may not be able to cover the complete opacity. There may be some opacity in the stroma left. So some people do recommend that if you feel that there is any irregularity, either after creating a femtosecond flap or there is some stroma, one could also use an excimer to smoothen it or remove the opacity. So that would be like a combination of a FALK with a PTK. So which can also create better outcomes. This is another case, interesting case from Dr. Vikas Mittal, in which there was a patient with a chemical injury which they had treated. Then they did stabilize the surface by doing a SLET procedure, and then they did a femtosecond based ALK. So this is a very beautiful case which demonstrates the use of surgery to be able to create the best outcomes possible for our surgeons, and this would be in a way an ideal way to do so. So I think this was an exceptional case presented by Dr. Vikas, and one can also use it. This is another case in which there was an anti-stromal scar post LASIK, in which they did a FALK and achieved good outcomes. So it has made it even more, femtosecond has made it even more precise. This is one slide which I had seen a long time back, and I asked Dr. Fogla to share it, in which they have done a femtosecond based procedure for a granular dystrophy, which had already, a PTK had been done a few times. So after a certain point, one has to do a transplant, and FALK is far more quicker in terms of visual outcomes and better than a deep lamellar procedure. So what are the advantages I would say of is that there's a lesser variation, although there still may be interface issues in some patients. And of course, the economics is the only problem with the femtosecond. Otherwise, as a tool, it seems to be a very good tool for corneal scars. Thank you very much.
Thank you. Thank you very much, Dr. Ashish. That was, again, another very thorough talk. When you're planning to do a PTK, Dr. Namrata, I wanted to ask you this. Would you look at going for the same depth, or would you like to go a little deeper, as long as you're within your safety limits?
I think I would like to go a little deeper than what my anterior segment OCT says so. And just going by the titled ALTK versus PTK, I think we published a paper 5-6 years ago where we compared PTK versus ALTK in cases of Salzmann nodular degeneration. And in those cases in Salzmann, we actually debrided the Salzmann nodules and then did the PTK. And we found that results of PTK were better than ALTK because obviously there were more complications, post-operative complications in the sense problems post-operatively after you do a graft, then after you do a excimer laser procedure.
How is the advantage of FALK over manual as significant as it is in refractive surgery in these eyes with corneal?
It makes a lot of difference because FALK, if you can do a FALK, then it really gives you a very smooth cut, provided it is not very deep, because as you go deeper, then femtosecond tends to give you a little irregular cuts. But if they are not very deep, then FALK will give you better geometry of the wound, better apposition, and you can, calculate the measurements and do it as opposed to a manual technique. But yes, ALTK also does, automated technique does better than manual. Manual is going to be irregular.
So other thing which I think Ashish spoke about was the size mismatch part, and femto gives you such a nice precision that you are not left with that kind of problem too much. However, in femto also there can be little retraction of the tissue. You should be aware of what kind of pathology you're dealing with. But to take care of that thing, what we can do is we can do a surgery like what first case he was showing using the LASIK microkeratome. We would do such kind of thing in 2 steps. So first step, we make a flap and just let it heal. The second step, I would go ahead and do a punch, vacuum punch in whatever diameter I want. And that time, whatever donor tissue I've taken, I take the same diameter there. Hence, we can match both these tissue precisely as we could match with femtosecond laser. Having said that, many times we can get quite nice tapering edges in ALTK, and hence small mismatch can still be managed quite nicely. Dr. Rajesh, you were saying something.
Yeah. I just wanted to add one thing. What I have felt in FALK, the edge-to-edge apposition is much better than SALK when you do with the microkeratome. And because it's a vertical edge, and in a microkeratome you get a
you can't control you can't control the geometry of the edge and
and plus in FALC the edge to edge apposition is absolutely perfect. It's a vertical to vertical edge apposition. So in a couple of cases wherein there are some reports of epithelial ingrowth after SALC, there is no report of epithelial ingrowth after FALC. And whatever experience I have, I felt that, in some mild scarring also, I have been able to do that, and it works reasonably well, provided, as Dr. Namita was mentioning, that it's not very deep. If it's very deep, then it will create problems. Otherwise, FALC, I feel, has an edge over microkeratome SALC for superficial opacities, as Ashish was mentioning, up to 200 or 250 microns.
And what about mitomycin C after doing PTK? Is there any second thoughts on that?
No second thoughts. I think I use it in all cases.
Yes. Dr. Imanshu, any other question?
No, I think we've covered most of the thing. I think we'll move on with the next topic.
Yeah. So I'm really thankful to Dr. Soham for coming forward the very, very last minute to talk on acute hydrops, and which Sheetal had to talk. And he's going to deal with surgical management options for acute hydrops. On to you.
Good evening, everyone, once again. So this is just something which was ready. I have not prepared for it, actually. Just let's go over it very quickly on surgical managements of hydrops. I have no financial interest in this talk. So are the slides visible, just to make sure?
Yeah.
So acute hydrops, as we know, it's not an uncommon complication of any of the ectatic disorders, be it keratoconus, keratoglobus, or even pellucids. It is also rarely seen in post-LASIK ectasia cases. The common presentation is sudden impaired vision with some amount of pain and the eye appearing white. So usually we do the conservative management where the healing takes place in two stages. There is reattachment of the DM followed by endothelial migrations. And there is spontaneous resolution seen after 8 to 12 weeks. And the commonly applied medications are usually a soft steroid, some cycloplegia, anti-glaucoma medications, hypertonic saline, and lubricants. However, there is no defined standardization of this therapy. So why go for surgical management when conservative management gives us a spontaneous resolution? So usually the idea is to avoid scarring. So it can either be a central or paracentral scarring. Sometimes there is a lot of neovascularization. Some of these scarrings may improve with a contact lens later on, but a central scar usually requires a corneal transplant. So doing an acute management is to avoid potentially a transplant later on. The clinical examinations that we need to do is, number one, look for any fluid clefts and DM break if seen. And in rare cases, sometimes there might be a coexisting perforation also, especially in the post-LASIK cases. The investigations, the anterior segment OCT is the most useful thing here. Previously, UBM was there, but now we have such beautiful OCTs. So that's the go-to test. We can locate fluid clefts, any descent detachments, and also we can serially, if we do, we can see how the stroma scars as the hydrops slowly resolves. Scheimpflug imaging of the other eye to detect any unknown, if not previously known, ectasias. And for research purpose, we have the role of in vivo confocal microscopy. Now, surgical management, there's a long list of surgeries. You can do either a fluid drainage only, especially if we have access to an intraoperative OCT. You can supplement it with intracameral gas, commonly C3F8 or also SF6, and then add on compression sutures also. So usually we do a combination of these procedures. And later on in scarred stages, there is the option of doing transplant, either a DALK or a PK. And there are some newer reports of doing an EK as a patch graft to seal the DM break. Rarer managements are like thermokeratoplasty, and recently described is the platelet-rich plasma injection in the AC. So gas tamponade, how it works is basically it brings the descents closer to the stroma. Commonly, we use 14% 3CF8 or SF6, which allows for a longer tamponade. Thus, the patient has to be maintained in a supine position for the next at least a week. And between the two gases, there is no difference in the final visual or transplant outcomes. Compression sutures, now various suturing techniques have been described. So one, you can do like a full thickness suture close to the break and sort of bring the separated edges of the DM together. Or we can have these overlay sutures, which are partial thickness, and the sutures are actually passing in the peripheral cornea. So you avoid the suture bite marks in the central cornea, which also adds to some amount of scarring. The overlay sutures are ideally given perpendicular to the DM break if you can locate it either preoperatively or intraoperatively. And then there is the venting incision. So it can be guided by IOCT, pre-op ASOCT, or UBM. And some surgeons have described identifying this using intracameral trypan blue, if the fluid clefts can be identified. So this is just an example of how the venting incision looks like. I have already filled the chamber with C3F8. And from the ASOCT, I know where the fluid clips are. This is 30 gauge needle going in. And you can see that there is egress of fluid once that focal area is ruptured. Here's a second area. And now, once this fluid has drained, now you can make out where the DM break is. It's in this sort of diagonal direction. Here it is more prominently visible. So now we know where to put the suture in which direction. So combined procedures is actually the preferred care. If you're doing a surgical intervention in acute hydrops, that's the preferred technique now. So there is good outcome in terms of both safety and efficacy, and reported by multiple publications globally. So short video on that. This is actually slightly older lady for developing acute hydrops, 39-year-old. So already in the slit lamp examination, you can see this vertical area of fluid clefts and also in the slit section. And once you do the anterior segment OCT, you can see there's a large area of fluid cleft, and probably in that area of red arrow, that's where the DM break is, because the irregularities are noted over there. There is no sharp hyperreflective line seen in that area. So this is the on table. So initially I went ahead and did the fluid drainage using a 30 gauge needle. Followed by very careful paracentesis. The main care here is to avoid any lens touch. So this is the overlay sutures. You take partial bite depths like a horizontal mattress, basically. So once these are passed, then you tie them real tightly. But the advantage is there is no suture bites in the central cornea. Take 2 or 3 such compression sutures so that the entire length of the break is well covered. So the gas bubble is sort of pushing the DM up from the inner surface, whereas the sutures are compressing this edematostroma from the outer aspect. So you have a flattening effect from both the sides, which leads to faster resolution of the stromal edema and eventually lesser scarring. So at the end, put a BCL on and of course ensure supine position. You can burp out some amount of air after maybe a couple of hours in the slit lamp. So this is at post of 7 days. You can see there is and this is finally at 1 month. The edema is almost well resolved. There are some suture lines. This is epithelial scarring. It will go off eventually. And in retroillumination, you can make out where the descemet break is. It's a fusiform break right there. And once we do the anterior segment OCT, you can see that there is scarring at the descemet level and probably endothelial migration is already taking place. So complications are Uret-Zavalia syndrome, pupillary block, glaucoma, and sometimes even malignant glaucoma. And of course, there is a higher percentage of developing a complicated cataract. So now the newer recommendation as described by Sunita Madam's group is doing a partial air fill, and this also gives a quite fast resolution. This is just showing immediate results. So this is at 2 hours and 5 hours. You can already see that even with a 50% C3F8 gas, the edema is resolving so fast. And finally, if there is significant scarring, you have to do a transplant. So the main thing here is big bubble technique to be avoided. Better to go for a manual DALK. And PK after hydrops, definitely the visual outcome is good, but it is associated with higher rates of rejection, possibly due to the vascularization which takes place in once the hydrops resolves. And nowadays, there is this concept of doing a small DSEK or a DMEK patch graft over the break in the hydrops. So this can sort of resolve the edema as quickly as possible. So finally, for management of acute hydrops, a good slit lamp evaluation and anterior segment OCT is the most important tool here. The surgery of choice is doing a compression suture with partial intracameral gas. And full air chamber nowadays to be avoided. And outcomes are usually good with contact lens fitting unless there is a dense central scarring. And eventually they can be, if the visual outcome is not satisfactory, they can be taken up for a transplant later on. Thank you very much.
Thank you. You couldn't have done better even had you prepared.
I know. I wanted to say the same thing, Chitra. We must congratulate Soham because you left nothing.
Before the program started, I told him.
He left nothing actually. It's a very complete talk.
Yeah.
Thank you, ma'am. Thank you, ma'am.
Dr. Basak is there with us? He's not there. I just want one question. Whom do I ask?
Sunita has done a lot of work on that.
I just want to
maybe
add
one thing we can add.
If you have an intra-op OCT microscope, then it really helps. And I think we've also published on this intra-op OCT guided fluid intrastromal drainage of the fluid as well as a gas tamponade both. And you can actually see the collapsing of the cystic spaces and the collapsing of the clefts right on the table. So that kind of really helps. Second thing is the UVM resolving index. We've described the hydrops resolving index in UVM. Again, that helps you to monitor the case. And this is published in ophthalmology. So I think these are the two things which are important.
Dr. Nikhil, I wanted to ask you one very simple question. There are some who think of giving repeat gas injections too. So if you feel so, what should be the ideal time interval between the first and the second? How soon should you do it? And how long would you wait for the edema to resolve?
I don't think I'm the best person to answer this, but I think in general, if you put C3F8, it stays pretty long inside. So I'm not sure whether...
Nita, you want to come in? You've done a lot of work on this thing. What are your opinion about and your technique?
Yeah. So personally, I don't favor gas at all. I don't use any gas. I just use only air at the time of surgery, just to get a plane at which where your Descemet's membrane breach is. Quite often you're able to localize, and if you use a light pipe, you can always see that sometimes. And technique is again partial thickness and just avoiding the center visual axis. So for let us say breach in the center, so I go from periphery to center. In keratoconus, let us say there's a breach in the center. So it's an arcuate fashion, and then the center part would be more like an infinity figure of 8 suture, just to avoid any suture passage into the visual axis. And then this suture, because it is partial thickness, now the compression sutures conventionally is reported to be we have to take it full thickness through the Descemet's membrane. But that in a way tends to cause scarring a lot more than what should be. So partial thickness does not cause so much of suturing, so much of scarring. And then these sutures, as what Dr. Namrata said, on table itself, when you're passing the suture bites, you see a lot of edema is already subsided on table. So basically you're compressing to bring it closer to the posterior membrane, and you see a lot of resolution right on table itself. So that's the usual technique I follow. I don't put any gas. Rather, I'll just put a very tiny air bubble, because I feel like that has a potential to cause urizevalia, secondary glaucoma, all such things. So I never use intracameral C3F8 or SF6. It's only 100% air.
That's really nice. However, having said that, I would say that there's no absolute thing in science. There are different ways of handling many things. proper care of making sure that the free gas bubble in the interior chamber without pupillary block has been used by many of us for a very long time, and it does work. Along with that, compression suture, and as Sunita was saying, so interestingly, we have so many different techniques. Whatever works in one hand, and even if one doesn't work, we have something else to fall back on.
Himanshu, I have just one question.
Please.
We see a lot of Down syndrome patients with hydrops, So is there any, because for them, anything to do would require anesthesia, they're not cooperative and things like that. So what is the recommendation? I think in institutes, maybe it's easier to give anesthesia, but in small centers, so do you follow the same guidelines or you have any different approach?
So Downs, I think, Sunita, you want to take up, you see a lot of such kind of children.
Downs have to be, Sunita can.
And Dr.
Yes,
Namrata, yeah. Both
yes,
of you.
Sunita, first you answer, then I'll answer.
Yeah, it's the same strategy. Again, Down syndrome, I'll be very cautious about using any sort of long-acting gases because they are very prone for sometimes expansion of the gases. So it would be again same technique. Yes, suture removal would be one of the things which maybe, if it's a large one, then certainly yes, they will require compression sutures. If it is a smaller one, I'll just prefer to go for a conservative management because generally like less than 4-5 millimeters, you don't really need to do anything. They just with the conservative management approach also they do well. Unless it's a bigger one where the child becomes restless because vision is compromised and they become agitated. So then would be the reason to perform compression sutures in those eyes, and then suture removal anesthesia will be required.
Is venting in
I think we do it differently. I would do all cases under general anesthesia and with SF6, not with sometimes with SF6, since most of the times with the C3F8 gas. Only thing is that at the end of the procedure, you burp it so that only the 2/3 fill up and not the whole chamber.
These venting incision, are they commonly done or very uncommon? And how do you avoid epithelial ingrowth? Do they happen?
If there are clefts, which now with all these things, with the changing diagnostic procedures like ASOCT, commonly available in our hand, there are many things which has changed, and one of them is venting incision. So when we see large clefts and all those things, earlier we didn't see them so often. So now we see them, we drain it out, and if we do not drain it out, the resolution is very, very slow, and sometimes there can be potential of having a fistula kind of thing formation. So of course they do help when we combine everything together.
I think one of the first publication was by Praful is here. Praful had written this paper on intrastromal drainage. So Praful had written this, and it was Dr. Vajpayee's idea, which we published. But at that time, we didn't have intraop OCT. So we wrote it as ASOCT guided. Praful, can you just...
So we published in both era, pre-MIOCT as well as during MIOCT.
Yeah.
And at RP center, we still follow that technique. We don't use this compression suture at all. And we have quite excellent outcome with this intrastromal drainage. Even with ASOCT also, you can localize the area of cleft and you can do it. Okay, that is the paper that we initially published. The results are as good as any other technique. And putting compression suture may be good enough for routine cases, but when you are dealing with Downs baby, and even the anesthetist is not willing to take up for the first surgery, then again taking the patient for another surgery, putting under risk of GA, I don't think that suits us. So what we do is we do this intrastromal drainage, and as ma'am said, like Dr. Sunita also said that usually we use air only. If we are 100% sure that all the clips have been drained and there are no chance of any fluid collection, then we leave it with air only. But as ma'am said, if there are little possibility, because most of the time you may not be able to drain each and every clip, or you are not sure about that, in those cases maybe SF6 is a good idea.
Right. Should we go on to our next speaker, Dr. Himanshu?
We should. Let's do it, because we have many interesting talks still lined.
We shall now go on to our next speaker, Dr. Arvind Roy, who's a senior consultant cataract, cornea, and refractive services from LVPI Vijayawada. and he is going to tell us about appropriate usage of intrastromal antifungals. On to you, Dr. Arvind.
Thank you, Dr. Chitra, for the opportunity. Do let me know if my slides are on screen.
Yes, yes, they are seen.
You're audible, Arvind, and slides are on screen. Thank you.
Okay. We shall be discussing another aspect of corneal surgery, the appropriate use of intrastromal antifungals. Fungal keratitis in a hot, tropical and humid climate such as ours is quite common. However, we do see a lot of variability in the clinical features, the treatment outcomes, the antifungal susceptibility. And this was what was found in some of the reviews that we performed on the subject. And we also found that this could be because of species level variation and also the geographic variation of the distribution of fungal keratitis that we see across different regions of the country. And therefore, that comes to this entity of the recalcitrant fungal keratitis. As such, fungal keratitis tends to take 6 to 8 weeks at least to resolve, and a non-resolution of 2 weeks post therapy with antifungals has been labeled as recalcitrant fungal keratitis, and in that different surgical modalities do exist which act as adjuvants. And sometimes fungus may be sequestered into the intralamellar corneal tissue, and this is also common, such as in the setting of a post DSEK or a post LASIK flap. And in such cases, because there are concerns about the penetration of antifungal drugs, these drugs may not reach the deeper areas of the cornea, and thereby that allows these stromal pockets to allow the fungus to proliferate. And this was one such very interesting report published earlier by Dr. Tu and his group, where they had fungal sequestration post DSEK 3 months, and this is the clinical picture, and the bottom is the OCT, which and also the confocal, which showed budding yeasts. So in such cases, intrastromal injections provide a depot or a bolus of the tissue at the site of where the infiltrate is, and therefore they provide a high concentration of drugs over there, which allow the drug to reach the area and allow in resolution. So these are some of the cases, but then as there is a lot of biological variability, and also there is a lot of variability from one patient to other. We definitely need to kind of customize the treatment, and there is no such thing as one size fits all. So this is one such case that that we saw recently of a 56-year-old male who was a diabetic. There were raised blood sugars, and this was a 3-day history. But in spite of 2 weeks of treatment, and subsequently the culture also yielded fusarium, and the patient was being treated with natamycin 5% with atropine. There were deeper lesions with a melting and almost a 40% thinning. And this is where we decided that because in view of the deeper lesion, the melting, and also the propensity to perhaps even thin out further or perforate, we decided to plan for intrastromal injections. So this was the clinical picture as the condition continued to worsen, and as we can see that there is a subtle melt, but most of the lesions were restricted to the mid to deep stroma, and there were plaques on the corneal endothelium. And at day 21, a decision for intrastromal injections were made, and this was 1 week post intrastromal injections, and all the time the patient was on topical therapy. Subsequently, we see that there is a area of scarring which was involving the mid stroma and also the periphery of the corneal lesion, and also the peripheral scarring and blunting of the infiltrate edges were also noted. In fact, with that, we also saw that there was some amount of reduction of the plaque, and subsequently the patient completely healed, and this was 11 weeks post-injection. And vis-a-vis in a very different clinical scenario, this was a patient who was again a diabetic, was subsequently controlled, but at 1 month history, we found that this was a patient who had filamentous fungus in the scraping. The culture yielded aspergillus species, but what we see here is a dense plaque in the central cornea, and there was a blood-tinged hypopyon. And at 1 to 2 weeks, we gradually saw that not only was the hypopyon increasing, but there was also a central melting. And almost at 2 weeks' time, there was a 2/3 hypopyon that was filling up the chamber. So this was a case which from the looks of it, and also we know that the aspergillus was very fulminant, and there was a lot of reaction in the chamber. We decided to plan for a therapeutic penetrating keratoplasty, and pretty soon, within 2 weeks of the surgery, there was a AC recurrence. And not only that, there was also a scleral extension, and ultimately the eye was lost. This was a failed graft. So how do we customize the treatment? So is it only because of the propensity of how fulminant the lesion is, where is it located, what kind of organisms are we dealing with? These are some of the dilemmas that the surgeon always faces. But having said that, in deeper lesions, sometimes it definitely helps to give in an adjuvant injection, and these are some of the injections that are currently in use for antifungal agents. So these include the voriconazole, amphotericin, or natamycin, which is in the sol form. The concentration that is recommended is a 50 microgram in 0.1 ml, and usually a tuberculin syringe is loaded up with the drug. The drug needs to be prepared, so this is not available per se, but it needs to be formulated and then injected accordingly. Typically, we do use the voriconazole and amphotericin B, but natamycin in its sol form has also been recommended, and even in a recent publication that was also found that natamycin in the sol form was perhaps little more effective in faster resolution, and amphotericin B in that study was found to induce more of vascularization. The mechanism is the same as for any antifungal medications, where polines cause a cell wall permeability, increase of the cell wall permeability, and azoles inhibit the ergosterol synthesis. This is the basic technique in which intrastromal drugs need to be injected. So after loading the drug in the tuberculin syringe and then using a 30 gauge or a 29 gauge needle, it is injected with the bevel down, and after that the degree of hydration of the stroma helps us note that the drug is adequately deposited in the medstroma. Usually 5 divided doses are given, and they are all injected as a barrage around the central lesion of the cornea, all in all. And after that, this procedure, we also continue with the antifungal medications. Typically, one can repeat 2 to 3 injections, and these are given after 72 hours of the first injection. So 2 to 3 injections after the first intrastromal injections have been recommended. There are different case series which have suggested that a targeted delivery helps in a safe and effective way to treat deep recalcitrant fungal keratitis, but that has also been refuted by other studies which also show that while the treatment has been successful with intrastromal voriconazole, but topical voriconazole in addition to natamycin is equally effective. So where do we go from here? That what is coming out from the body of literature that we have at hand is that intrastromal injections are definitely an adjuvant, but one needs to customize the treatment on a case-to-case basis, and then always use clinical judgment while using any of these techniques. And at the same time, the mainstay of treatment still continues to remain the topical therapy, and the resolution is very dependent on the fungal genotype, resistance pattern, glycemic control, and the load of infection. Thank you very much for your patient hearing.
Thank you very much, Dr. Arvind. That was a wonderful talk and very detailed. I have one question. When would anybody think of combining intrastromal with an intracameral injection? And if so, would they be giving more number of injections, or is it done?
We can do that. The intracameral injections tend to kind of assist after washing out any load of infection that might be there in the anterior chamber. with again supplementing those diseased tissues with a flush of the antibiotic that remains. However, because of the clearance of the drug, which is about 6 to 8 hours, practically no drug remains in the anterior chamber. Therefore, intracameral medications have a very short half-life, and therefore they do not really add much to the effect of treating these infections. Therefore, the intrastromal, on the other hand, is more of a bolus dose, which is pretty much there in the stroma, and therefore it has a longer longevity in the tissues.
Dr. Namrata, you want to come in? You've been using.
I think Arvind has covered it very nicely, and he's covered it very completely also. And he's right. Although I have a little tendency, if I see that there is a hypopion and I'm giving intrastromal, I would also give intracameral. And but just for a hypopion, I would not give intracameral. But if I'm giving intrastromal and there is a hypopion, then I would give intracameral. But there is nothing to suggest why it is done. It's purely anecdotal. But I think he's put it very nicely. Arvind has given fantastic
Dr. Namrata,
presentation.
your
I
selection of cases. Can you tell us where would you think of giving intrastromal? Which cases? At what point you decide that, you know what, now intrastromal?
So if there's a recalcitrant fungal keratitis which has not responded to topical and systemic, by topical I mean topical combination therapy, natamycin, voriconazole, and your systemic medications for 4 weeks, then I would give intrastromal. I mean, that is what we have said in our TST protocol, which is topical, systemic, and targeted therapy. TST word was coined by Praful, who's again sitting here. But that is how we do it. But having said this, they should be given earlier than later, and very nicely shown by 2 cases of Arvind. In first case, where they gave it earlier, it resolved in this. In the second case, where actually it presented late and it was already going up to the limbus, there it is not going to help. You have to have a clear corneal area around the lesion, only then it helps.
Is there a role of intrastromal voriconazole for acanthamoeba keratitis?
I don't think anybody has tried. People have tried only topical voriconazole for acanthamoeba keratitis with limited role. I mean,
we
use
systemic fluconazole for those where we suspect a scleral nodule or adjacent scleral involvement. But I agree with Dr. Namrata. We have not really tried.
Himanshu, any other question? We go on to next speaker.
I think we go on to San.
Yeah. So really, truly happy to have Dr. San with us, who's a network director of research and cornea, cataract, and anterior segment surgeon from Keratoprosthesis, Hyderabad. And he's going to be telling us about how to improve outcomes with SLET. On to you, Dr. San.
Thank you so much, Dr. Chitra and Himanshu. I guess I made it just in time.
Yeah.
I'll be quick, just touch upon a few points and maybe just talk about the surgical technique a little bit. So this is what a normal ocular surface looks like. The normal luster appearance of the cornea, and the typical white eye, how the limbus looks like on your top left, what a normal cornea looks like on OCT line scan, and also what the limbal vessels look like clinically, and also on OCT angiography you have this typical hairpin loops. These are all features of a healthy ocular surface in an absolutely normal eye. On the photograph on your left, you have a patient with a slightly more pigmented limbus. This is just to highlight that the pigmentation of the limbus does not denote normality or abnormality. These are ethnic variations. You can have somebody with a prominent brown limbus like you have on the left, or a fairly non-pigmented limbus like I showed you before. But what we're trying to look is to identify the palisades and the limbal vessels. So on the right, you see a patient with an inflamed ocular surface. You cannot identify the limbus. You can see that the limbal palisades are stressed, the cornea is vascularized, inflamed, opaque, and this is typically what we refer to as limbal stem cell deficiency. So where the limbus, where the palisades of Vogt reside, where the stem cells are, is distorted, and the normal corneal phenotype, epithelial phenotype is lost, and that is replaced by scar tissue, which is basically what we refer to as a fibrovascular pallus. So when you are faced with a patient with limbal stem cell deficiency, if it is unilateral, this is where we try to look at whether visual acuity is present, and we try to avoid eyes which are dry or have adnexal problems. And in a wet eye without adnexal problems, it's a good eye to, good case to do autologous limbal stem cell transplantation or SLET without conjunctival autografting. We usually do not combine it with a penetrating or lamellar keratoplasty because in a lot of cases, SLET itself results in stomach clearing. And I'll show you a couple of examples of this. Bilateral LSCD is a much different animal altogether. Here, there are more options because we are more desperate to restore vision to the patient. Not so much in unilateral cases where patient already has a good seeing eye, and therefore the options are a little complicated. You can do allogenic SLET provided the adnexa is normal and the eye is wet. Otherwise, there are different complicated types of keratoprosthesis which can be done. This is not the topic for discussion today, so I'm going to restrict myself to what is on the left of your screen, which is unilateral limbal stem cell deficiency. The first thing, of course, is to make sure that the case that you're selecting for the surgery, as the number one tip for making sure a surgery is successful, is that it is really a case of limbal stem cell deficiency and not a masquerade, because then you'll unnecessarily be doing stem cell transplantation when it's not required. Typically, you can have any chronic inflammatory disease of the cornea or the ocular surface present with vascularization and scarring. It's not necessarily limbal stem cell deficiency. And therefore, we think that the most important objective way of identifying this is OCT. You can just look at a line scan. If you have a hyperreflective epithelium, then that means it's LSCD. If you have a hyporeflective epithelium, it means that it is a patient with a normal cornea, and you're looking at something else. There are, of course, other ways of doing this with confocal microscopy and impression cytology, usually not available. OCT everybody has. So if you are going to choose between the techniques for all practical purposes, SLET is the most practical approach to do. We have a lot of experience with SLET, but right now it's regulated therapy, hardly available anywhere. There are some commercial products available, but in India, if you're looking at, you hardly have any options. SLET basically works fill in the blank technique. You put small bits of limbus and the cornea epithelizes from those bits and covers we have a lot of parallels in dermatology of similar techniques. One is called the DMEK technique for treating acute burns, and also there's a very interesting technique for vitiligo, which is on your bottom right, where a similar approach is taken, where small bits of pigmented skin is taken and transplanted in the area which is lost pigmentation. So essentially, you remove the pathological tissue, create a bare sclera and a bare corneal surface, put in the small limbal lenticules from the healthy eye, and then the rest of the cornea epithelizes from that. So there's a lot of evidence in literature to show exactly how this happens. As you can see from the fluorescent stain images on top, epithelium growing out from all these small tiny bits of limbus, forming islands, those islands then forming large continental masses and then fusing together to form a continuous sheet of epithelium. The same thing can be seen on the OCT scans as well. You don't want to do SLET where you're not sure about the cause of LSCD. It is not a wet eye. The corneal stroma is damaged, and there's a lot of, especially in a case of adrenal glaucoma or disorganized anterior segment, the adnexa is damaged. So you want to make sure that the adnexa is treated, whatever entropy or ectropy is taken care of. And the best cases are unilateral, total LSCD, usually with alkali burns and without severe symblepharon. So the OCT also comes in handy, the infrared image and also the line scan, in making sure you are not falling into a trap. So sometimes very thin corneas can look very clear. And at the same time, the infrared image basically tells you what is the relative stromal clarity underneath. You don't want to be operating in a very thick stroma, which may have endothelial dysfunction, etc. So for all these cases, these are all cases of LSCD, but not all are suitable for SLET. Only the ones that you can see on top, where the ocular surface is wet, the lids are normal, but the patient has total LSCD and underlying stroma relatively appears clear. I can see, make out a little bit of the pupil. These are good cases. Whereas the cases at the bottom, where there is entropy on dry surface, etc., these are bad cases. Also, in cases where there's severe symblepharon, you need to combine with a conjunctival autograft, which is your second row. And in the third row, basically shows cases of pseudopterygium or partial LSCD, which can be treated with a conjunctival autograft alone. You really don't need to do SLET in these cases. So I'll just take you briefly through the surgical technique. Unilateral cases, you're looking at the fellow eye, you create a small bleb near the limbus, lift the conjunctival flap. So this is a limbus-based conjunctival flap, dissect down to the limbus, and then take the limbal biopsy. This is the most important part of the surgery because what you're grafting is going to be the healthy limbus, and so how well the cornea epithelializes depends on how healthy your graft tissue is. So the limbal graft in SLET is as important as the kidney graft in kidney transplantation. And so once you have obtained the limbus, and this is usually without the conjunctiva, we are looking at pure limbal tissue, and then you move to the eye which is damaged. We do a little dissection, remove all this pannus, and sometimes you have to do a combination of blunt and sharp dissection. I'll just move through this. And eventually, when you have a bare ocular surface, first you put down the amniotic membrane, secure it with fibrin glue. You can also put circumferential sutures and secure this with 10 or 9-on. And once the amniotic membrane is, secured, usually you have to make sure that it's nicely put down and you trim the edges. Then you take the limbal tissue, cut it up. I prefer using a Vanna scissor to cut it into small pieces, usually from 1 clock hour of donor limbal tissue, which is about 3 to 4 millimeters. You can make about 8 to 10 pieces. We put that in the mid-periphery epithelial side up, and then put 1 drop of glue on each piece. The first part, which is the thick part, fibrinogen, and then the thrombin part. Usually when we put the fibrinogen, we spread it out a little bit so that the thrombin, which is more runny, sticks to it when it comes out. And once this is done, that's basically the end of surgery. So it can be completely sutureless surgery, although we do recommend putting nylon sutures for the amniotic membrane for children, and as well as a tarsorrhaphy if required. And this is typically how the surface heals. A normal corneal epithelial phenotype is restored within a few weeks, and this usually lasts forever because it is autologous. There's a lot of evidence in literature to show that the success rates are close to 80%. In recent times, if you now with the evolved knowledge of what the risk factors for problems are, and like I said, if you avoid dry eyes, if you avoid eyes with adnexal problem, your success rate would be between 90 to 100%. Just to show you a few examples, this was a case that I operated in 2011. You can see very inflamed surface, vascularized stroma, even 6 weeks after SLET. But this has continued to improve with improvement in stromal clarity and patient's unaided vision over the course of the next 7-8 years. And this typically happens, and that is why we say that you need to hold your breath for a while and not go in for an early PK. This is obviously, probably the most famous case of SLET or marquee case. A lot of, you may have seen this before, patient presenting with a granuloma, and then 8 years later, the patient with a normal looking eye, and even as severe cases of LSCD like these can be treated very effectively with SLET. Another case with a young boy with Chuna injury, and the same eye 2-3 years down the line. If you saw this child, you would hardly be able to make out that the child has had surgery. So, we have been working a lot, teaching people about SLET all around the world, and it's extremely popular now. And I think there's a lot of evolved knowledge that everybody has, and I think a lot of people can share their personal experiences with it. We have also shown that the limbal transplants retain the stem cells, and that is why you have long-term, surface regeneration with it. And we are looking at also at the biology of how SLET works, especially how allogenic SLET works. Just a couple of things before I finish. One is that the limitations of SLET are, like I said, in partial LSCD pseudopterygium, which is a case on the bottom. You might do a mini clow or a CLAG, which might work. And those with opaque stroma, where you're combining with a LK or PK, I prefer doing a mini clow. And the reason for that is, and these are the two indications where I prefer a clow over a SLET, or just a conjunctival autograft. Because the corneal graft, it can have interface vascularization, and a PK is always a high-risk graft. So when you have to repeat the PK, which is quite likely, especially if the patient is young, you don't have to repeat the limbal transplant. If you do a SLET, then you have to repeat the SLET. So that is the only limitation I feel where a clow scores over a CLET. So we know with our combined experience over so many years, or close to a decade or maybe over a decade, and so many people using it, that it's an excellent surgery that gives very predictable results, provided that you keep these pearls in mind and avoid the cases in which not only SLET but any form of limbal transplantation fails, like dry eyes, adnexal problem, etc., where you need to do stem cell transplantation is not the correct approach. You need to look at other alternatives like keratoprosthesis, etc. Thank you so much.
Thank you, Dr. Sain. That was a wonderful talk. Now, supposing you have to do a PK after SLET, what should be your time interval? How long would you wait?
So I think that I would wait several months. Usually the stroma clears quite a lot significantly. And like I said, in unilateral limbal stem cell deficiency, where even the patient, etc., is not as demanding in terms of vision, they're very happy with the cosmesis and usually with the fact that their symptoms are much better. And because they can see from the other eye, they are usually quite satisfied with the outcomes, and they don't insist on, like perfect vision, or cosmesis may be an issue. So if the cornea is relatively opaque and, we have not achieved vision as well as cosmesis, that is when I would think about it, probably not before 3 to 6 months of doing SLET.
Supposing you're going to do an AIOS, what is the kind of immunosuppression you will give and for how long?
So in AIOS, first of all, case selection is very important. I think the best cases for AIOS are patients with chronic allergic conjunctivitis who develop a limbal stem cell deficiency because their eyes are wet and they do not have any lid-related problems in terms of entropion, ectropion, lid closure, lag of thalamus, etc. However, the cases that we might be seeing of bilateral LSCD, maybe most commonly patients of Stevens-Johnson syndrome or pemphigoid, these are difficult cases to treat. And therefore, the first thing that I'll say about AIOS is if you're doing it for bilateral severe allergy or chemical burn, that's a completely different scenario. If you're doing it for an underlying immunological disease, I would say avoid it. Don't do it. Send it to somebody who has more experience because immunosuppression alone will not cut it. But with allergic conjunctivitis and chemical burns, we typically give the patients a combination of steroids and cyclosporin to begin with, oral. And you can maintain these patients very well on oral cyclosporin, steroids and stop.
Okay. Here, Dr. Imanshu.
I think Sain has taken everything. I really don't think anybody can have any question here.
Imanshu, I just have one comment.
Please,
I just wanted to ask Sain. Sain, I think in these cases where you do SLET or you do CLET, more often you have to do a DALK than a PKP. I'm not saying it's not there, it's there, but most of the times the Descemet's membrane is clear in these cases. What do you say to that?
No, I agree. Whenever possible in these cases, you try to do a DALK if the stoma is opaque and you have done SLET and restored the surface, then if possible, then that. PK for endothelial dysfunction also, we tend to do less nowadays. Like I have done, I'm sure you have done, I mean, Imanshu must also have the experience, and I'm sure Dr. Namrata has also done. I've done a few cases where I've done SLET, the corneal clarity has not improved, but I realized that it's because of endothelial dysfunction. And then I've done a DSEK later on. And these patients also tend to do pretty well. So I think it's between DALK and DSEK. I mean, PK, hardly ever.
One thing about DALK, where I would be a little careful about, and I've burned my fingers there, when you have very bad vascularization, I have had a couple of times where there were sterile melts, and for unknown reason, which I was like not able to explain. And those blood vessels, which so again, the scarring and vascularization was such that I could not get rid of many of those vessels, and I had 2 cases where I had sterile melt, and so bad blood vessels, stromal vascularization, something I would be a little careful there.
Thank you.
Have you seen vessels on the Descemet's membrane growing ever? I don't think. I mean,
yes, I have.
If you leave,
I have.
You leave on the stroma. I mean, if you leave a little bit of stroma, then, but if you do a desmetic DALK, then it's rare to find.
Many times, Dr. Namrata, because of scarring and all those things, it may not be very practical that we get big bubble there, or it may be pre-desmetic. So, well, I would just say that if we are able to get a nice deep stroma, well, that's best, and I would surely endorse that. But just keep in mind that there were quite significant good outcome in these cases. There can be sometimes something like this can happen.
Thank you, Dr. Himanshu. We shall go on to our next speaker, Dr. Vinay Pillai, who is a senior consultant and head of cornea and refractive surgery from Giridhar Eye Institute. And he is going to talk on managing delayed post-op complications of keratoprosthesis and how the tips to retain K-Pro.
Thank you, Dr. Chitra, for this opportunity. Yes. Once again, yes, we are back to K-Pro from the other extreme of cornea. I mean, corneal disease to the extreme end. So, like any condition, it's always better to prevent complications from arising than to address it. So, and it starts right from preoperative patient selection. So, the most common K-Pros which we use now are the Boston type K-Pros and the in the dry eye, I mean, osteokeratoprosthesis. So in Boston type, we have to be sure the ocular surface is otherwise healthy, other than the stem cell deficiency or things like that. Normal lids, wet eye, while in dry eyes, it has to be the OKP. Intraoperatively, well, you can have things flying around, especially when you're assembling a K-Pro. When you're punching the donor cornea, if it becomes eccentric, it can have, back plate protruding at one end. And when you're assembling again, you can have the back plate breaking. Now, Oro K-Pro, which is the Indian variant, we have to be careful because at times, we have an LVP variant of Oro K-Pro, which is slightly different from the Boston type of Oro K-Pro. So we are planning for Boston type and you get an LVP K-Pro, it is very difficult to, assess initially till you reach the end of the surgery, or rather when you start assembly. Then the routine problems like bleeding, expulsion of the lenses, supracortical hemorrhage, and so on. And in OKP, there are certain special things like when you're harvesting the mucosa can be damaged, or you can have a buttonhole. When you're harvesting the tooth, it can go into the antrum, causing a fistula. You can have damage to the adjacent tooth, or there might be excessive bleeding. Postoperative immediate problems can be leak, which can be perioptic or from the graft-versus junction in Boston type keratoprosthesis. There can be bleeding into the anterior chamber. Intraocular pressure can be high and low, maybe because of leak or other causes. In Boston type, maintaining the BCL on the surface can be a problem if the ocular surface is not normal or ideal, like inflammation, infections or other problems. Now, why is the delayed complication important? Because all these keratoprostheses, if I may say so, may be considered as time bombs. Okay, they can explode on your face anytime. So a high index of suspicion for problems should be there. And at each visit, we should actually actively look for problems that can arise rather than just a routine screening. Some signs that help in, predicting some problem later, like air bubble under the BCL, which can cause the desiccation of the epithelium and breakdown and further problems like infection, persistent defect, melt of the graft, and so on. So the other sign is when you're staining a Boston type keratoprosthesis, if there is pooling of the dye under the anterior plate, it shows that the graft has kind of thinned off and can result in later problems. If the optic cylinder is slightly mobile, and all these cases, whether it's an OQP, whether it's a Boston type keratoprosthesis, we should always touch the optic cylinder and see how they are, whether they are stable or if there is any mobility. Change in refraction is an indirect indicator of tilt in optic cylinder, again, because of the melt or problems in the haptic tissue, either cornea in Boston or the bone tooth complex in MOKP. Vision can drop because of various reasons. Intraocular inflammation, either sterile or infective, can be a reason, or retroprosthetic membrane can be another reason, which is quite common in Boston K-Pro, but at the same time, it is not that common in posterior keratoprosthesis. Now, graft melt is a serious issue in Boston type keratoprosthesis. It can be, as I mentioned before, BCL related desiccation induced melt, or because of ocular surface problems, either mechanical or immune mediated, and then a thick RPM itself can induce melt. ASOCT in Boston type keratoprosthesis helps in identifying perioptic melts, also helps in assessing the angle, epithelium covering the front plate, RPM. But in osteodermokeratosis and type of keratoprosthesis that we use in dry eye, it does not penetrate the mucosa, so it has got very limited role in these conditions. Glaucoma, again, can be pre-existing, which can result in progression after keratoprosthesis, or can be a new glaucoma that is developing after the implantation of the K-probe. It is practically not seen in osteodermokeratosis, that is the de novo or the new glaucoma post-keratoprosthesis, but is not very rare after Boston types. Infection, again, it's a real problem in Boston type keratoprosthesis, especially in our environment. It can be, infection of the graft, which initially can be managed like any graft infection, but then at the earliest sign of, lack of control with a conservative management, they should have a surgery, and we shouldn't wait for it to melt and or result in, irreparable damage before we decide on intervention. Endophthalmitis, again, can be devastating in these conditions. Other, intraocular inflammation, which we see and which is not very rare, is sterile vitritis, and that again is more common with Boston type keratoprosthesis. How we differentiate from infection is that most of the cases are painless, and that causes just a reduction in vision, respond to steroids, and there can be multiple recurrences, which gradually over the period of time can result in permanent reduction in vision. Specific to osteodermokeratosis or other type, which is similar to OKP, is mucosal changes, which can be trophic changes, melts with exposure of the lamina, which may be managed with a pedicle graft, or many times we may have to resort to through the lid keratoprosthesis. Laminar resorption in the long run is another issue, but then it is a pretty late complication, and again, very limited options in these conditions other than removing the lamina, either go for a new lamina or change the type of keratoprosthesis. So in short, in keratoprosthesis, consider complication as a norm. Okay, almost all of these cases can have problems sometime during the follow-up period, and which makes it important that preoperative assessment of these patients, not just ophthalmologically, but then about their social background and the ability for a lifelong follow-up is mandatory. Thank you.
Thank you very much, Dr. Vinay. A question for you. When would you think of combining K-Pro with a glaucoma drainage device?
Combining is mainly done in Boston type keratoprosthesis. If there is a significant glaucomatous damage, which we could identify prior to doing the procedure, or if the patient has to be on at least 2 drugs to control the pressures prior to K-Pro, it is always better to combine.
Has anyone would suggest doing a repeat K-Pro for any patient?
Yes. Sen, you are,
See, philosophically, K-Pros are like this. It will either come out, or if it stays in the eye, the patient will go blind from glaucoma. So you're stuck between a rock and a hard place. But like Vinay mentioned, the philosophy with K-Pros is that, these are very desperate people with very severe blindness, and we really can't do anything else for them. So we do a K-Pro, we try to have the patient retain the K-Pro and at the same time protect the optic nerve, control the glaucoma. But life for a patient with a K-Pro is from one K-Pro to another K-Pro. It's except for the OKP, that also not always, but in an OKP significantly better than others. But the Boston type 1 is what we commonly use, and there you're basically going from, you can't expect that the patient will have the same K-Pro in their eye for a lifetime. It's very unlikely. The patients who do end up having glaucoma, and you have some of these patients who have wonderfully retained K-Pro but can't see. But typically it's from one K-Pro to another K-Pro. So repeating K-Pro is quite common. Anybody who's doing K-Pro practice, I think at least 20-30% of their cases are just repeat K-Pros.
Thank you.
Can I ask a question?
Yes, yes.
Sayan and Vinay, so do you like to do a conjunctival flap or Gunderson kind of thing as a primary procedure when you are doing a K-Pro specifically, in cases where it's really bad surface? Because we know it's mainly the epithelium that, causes issues, especially in, first 1 to 2 months time. So do you like to do that?
No, I have done it, Vinay, Vikas. But the problem is that in the cases that you really need it, you don't have enough conjunctiva. That's the problem. So the only case that you can actually do this is in chemical burns. That also, the problem is that these would probably be cases where the conjunctiva is okay. So you can probably even get away with an AIOS. You don't even have to do a K-Pro. So it definitely helps, but finding those cases is very difficult. Just like doing AIOS in OCP or SJS, to find an SJS or an OCP case that has a wet eye, that has normal eyelids, that has normal closure, it's very difficult. Rarely you will get a patient where you can do that. It's the same with conjunctival flaps. The cases in which you actually need it, you don't even have enough conjunctiva.
Yes, true.
Thank you.
So Vinay, if somebody, a newcomer, has to do K-Pro, which will be the best case to select, and which will be the red flag not to select?
Well, the best case will be for Boston, to start out with Boston K-Pros. Okay?
Yeah, Boston. Let's stick to Boston K-Pro because only gods can do.
So obviously the bilateral disease, right? Normal lids, deep fornices, normal lid action, wet eye, okay, total stem cell deficiency because of any reason, right? These are the cases that
and
can
if
be.
you can.
What do you think about repeat grafts? I thought repeat grafts would be the easiest for a person to start K-Pro.
Yeah, again.
You have multiple 4-5 grafts.
Yeah, but then bilateral.
Yeah,
it can be repeat graft, it can be chemical, it can be, any condition which is resulting in bilateral, corneal scarring, which is not amenable to grafting again. But then the rest of the surface should be normal.
Sure. So, Sayan, any indication if you want to put, as in, not the findings, but any pathology which, if somebody's first case, like say repeat graft or LSCD, or what would you suggest?
No, definitely. If you have a case of a multiple failed graft, like Dr. Namrata was suggesting, that's the best case. The only thing is, nowadays for multiple failed grafts, we usually do a DSEK or a DMEK, and that works very well. So it would be a very complicated case of a failed graft where the AC is very shallow and there's pus all around, but the surface is fine. That I think would be the best case to start with, provided you have some glaucoma support. Somebody can put in a valve if required.
Thank you. We shall now go on to our next speaker, Dr. Vikas Mittal, who is the founder of the LJ Eye Institute, Ambala, who's a corneal and laser vision correction center. And he's going to be talking on corneal tissue additive procedures in keratoconus management. On to you, Dr. Vikas.
Yeah, thank you so much, Dr. Chitra, for this opportunity. And it's a lovely session going on. So from surface, we'll go slightly down. We'll see that how best we can add tissue in the cornea. Okay, so I'll start with a case. This 20-year-old boy who had a progressive keratoconus came for consultation in the right eye, had undergone transplant in left eye 3 years back. He was not very happy with the vision, mainly because of astigmatism, and in both eyes with contact lenses, the vision was fine. This was the tomography. You can see that K was more than 65 diopters and pachymetry was close to 300 odd microns. So what options do we have? He has good vision with contact lenses and the pachy is 300 microns. We want to stabilize if possible because he can use contact lenses. But how we can stabilize this? Cross-linking and 300 microns will be very challenging and patient didn't want to do, any DLK or PKP. Is there anything else? So these are the kind of patients where the thought process of cornea tissue additive procedures came in. And let's go through what all have been described so far. It started with Dr. Mellis describing Bowman layer, only Bowman layer going inside the cornea. And the reason, the rationale was in keratoconus, you have a fragmented Bowman layer. So the support is lost. So if you place a Bowman layer in the stroma, it might cause the stabilization of keratoconus. And they have, more than 5-7 follow and bound with Bowman layer as an additive procedure is the stabilization. The challenge is that the surgery per se is challenging, is sometimes challenging, and that's why most of these reports are from single center. Is there anything else? There are, more than half a dozen articles on use of smile lenticule. The smile lenticule that we remove from a myopic refractive surgery can be placed inside the mid-stroma of the cornea. Here again, they have found that it gets accepted pretty well, and there is a stabilization of keratoconus when we transplant the smile lenticule into the cornea. Here, we would be dependent on a specific femtolaser, which can cause, from where you can do a smile, and then there'll be no Bowman layer in this lenticule. So what we did was we tried to use both Bowman layer as well as corneal stroma as an additive procedure to strengthen the keratoconus cornea. So how you do it is just remove using femtosecond laser, harvest anterior 180 to 200 microns from a optically clear donor cornea, and using femtosecond laser create a pocket in the recipient cornea, and then place this inlay inside this pocket. Because it has both Bowman layer and anterior stroma, and it is placed intrastromally with Bowman stromal inlay. Let's go through this video to see what exactly is done. So this is the patient eye. So first patient eye is DALK. We are planning 9.5 to 9.8 diameter of intrastromal pocket. You can, change your, even LASIK software can be used to create this pocket. After the patient eye is done, now you are mount this artificial donor cornea on the artificial anterior chamber. And plan was to create 180 to 200 odd microns anterior stromal graft. First epithelium is removed using alcohol. The limbus is marked, and then routine docking is done. So we need to ensure that your this inlay is within those marked areas. Once it is marked, you can remove this, and this harvested is stored in BSS. Now the patient is taken into main OR, and the pocket which has already been created can be opened with any blunt instrument. As you can see here, just like those smile instruments also, with that also you can open it. It opens pretty well. Now the inlay is loaded onto the routine IOL injector with Bowman layer side up, and then this will be injected into this pocket, and it goes pretty easily. The feel here is, and this once it goes inside, you can open it using any cannula, and centration can also be done by a surface massage. The feel is more or less similar to what we see after DSEC, the unfolding and then straightening or centration. And once you do this, you don't need to suture anything, and the surgery is over. So there is a tissue additive procedure. We have transplanted Bowman layer and anterior stroma into the patient's keratoconus eye. Generally, first week is slight edema, but it's settled down within 1 month time. And after 1 month, it's hardly visible. Although we have two interfaces, you can see the same patient. Just look at this pachymetry map here, 300 microns to it has become 500 plus microns. So we had reported first 10 eyes in JCRS, where we found that it is surgically very easy, no specific surgical skills or specific learning curves. Anyone who's comfortable with LASIK can do it. No specific intracorneal. We didn't see any folds or interface haze during follow-up anytime. Increase in pachymetry is very predictable, and posterior float as well as keratometry remains stable. And few of these patients are more than I think 3.5 years follow-up, and they all are very stable. The keratoconus is stable. Vision was more or less same as it was pre-operative. There were change in tomographic parameters, but these were not statistically significant. This boy, we had done one eye Bowman stromal inlay and other eye cross-linking, and we found that over a period of now it's 3 years, the both eyes are stable. So it was head-to-head comparison, and then we compiled our 5 patients which have been followed for 20 months, and what we found was both eyes were stable. So that means the BSI efficacy in stabilization of keratoconus seems to be equal to what we have a gold standard collagen cross-linking, and the Kmax tends to decrease in BSI, and pachymetry of course will increase in BSI or additive procedure. So as I said that, tomographic parameters doesn't change much. So we thought that maybe we can customize the shape of this inlay to achieve a lower or flattening of cornea. So what we can do here is, on the stromal side, you can ablate it, make it a negative meniscus inlay, and then you implant it into the midstroma of the cornea. So there you may achieve a central flattening. So I'll just go through this video. So here, what we have shown you. So after harvesting of this inlay, this is flipped. So it's flipped. Now the stromal side is up and Bowman side is down. And this whole thing is shifted onto the excimer laser, and the center 70 odd microns, we have done a PTK. So overall it was 8.5, 8.25, and the center 4 mm, there was a PTK. And then you can see the post-operatively, it was pretty fine. The center, you can see it's thinner than in the periphery. And the tomography, you can see the K from 69, it went to 57, improvement of vision minus 7.5 to, +1. So we actually achieved a flattening of cornea as well by customization. So overall, when we do any additive procedure, it can strengthen the cornea. Stabilization of keratoconus is, quite consistent in all the records, all the literature, and what we have found. And in few cases, they have been reported a flattening as well. So suppose you have a, thicker cornea now, you can always, for visual rehabilitation, you can do a future topo-guided PRK. Suppose in case this ectasia still progresses, you can always do a cross-linking, and this time it will be a thicker cornea. It will be much safer for the endothelium. And you can change the final topography by changing the shape of the inlay that you transplant. So here again, I think a lot of work can be done, and we might be able to come up with some nomogram that how best we can make it very predictable. So for the time being, this is another management option for cornea surgeons when they are dealing with keratoconus, especially when the cornea is not fit for collagen cross-linking. Thank you so much.
Wonderful talk, Dr. Vikas. That was truly informative. I don't think there's need to put these patients on steroid drops for long, no, because placing a lenticule inside,
Yes.
infection issues are not there at all, right?
So you see, there are keratocytes, so we generally give them steroids for at least 3 months, and then watch in case, for any reaction. So far, we didn't see it, but you cannot rule out. So even in DLK, it's not that rejection will not happen at all. So you need to be careful. We generally give predfort for 3 months, and then loteprednol for at least 6 months. So total around 6 to 7 months, we give them steroids.
Okay.
Because one question to you that. What would be your final goal? How are you targeting to visually rehabilitate this patient? Or rather, when you counsel the patient, how would you counsel the patient that what is your plan? What are you going to do ultimately?
So now, after we have done close to 60 odd patients, so we are sure, suppose the patient has good vision with glasses, and the patient is fit for cross-linking, there's no need to think about anything else. Only when the patient doesn't have good vision with glasses, we see that if with contact lenses vision has good, so we tell them that, see, you are not fit for cross-linking, we can go ahead with the additive procedure which will stabilize the cornea, and for visual rehabilitation we can always give you contact lenses. Sometimes when they are high myopes, those and cornea is very steep, we achieve some flattening also, but we don't promise that. I think at the moment we can promise that it will stabilize. That is for 100% sure. Most whatever we have seen so far. For making the patient visually rehabilitation, that will again depend on glasses and contact lenses. Regarding topo-guided PRK, we have done in couple of patients, but I don't think that we got the result that we actually expected. So that thing, but you can always do it. So that maybe sometime later we might be able to understand it better.
Amount of astigmatism will be pretty significant, no? There's also a limit of how much tissue can remove in topo-guided. So I think it
Yeah, that's
becomes
right. That's
clear
right. So suppose you are going at 130 microns, right, deep. So if you remove anterior 50, so you have close to 50, 60 microns to play around. So you can ablate, 50 to 60 microns. You have to take into account the compression that you will have. So those tissue you can ablate. Of course, you don't want to hit the new bowman layer that you have implanted in the cornea.
So I have one question for you, Vikas. There is going to be some attrition of the tissue because it's a human tissue over a period of time. So what is the longest follow-up you have? And
So longest follow-up is 4 years now, close to 4 years. And in one girl who had very severe VKC as well as very severe Kekonus, she had shown some resorption sign, but she had other eye which we didn't do anything because, in a VKC patient, it's very difficult to do cross-linking. And that eye went into hydrops, and, we have that planning for Kekonus. In that, apart from this eye, we have not seen progression of ectasia so far.
But what about thinning of your lens
That's what.
that you implant?
So this girl, there was some thinning as compared to previous one, but rest of all, I think so far we are maintaining the same thickness. I don't know, maybe most of the tissue that we are using are 50 years plus. So these are the tissues, the donor tissue which are naturally cross-linked. I don't know if that is causing some beneficial effect, but so far, apart from this couple of these patients, we have not seen resorption of lamina over a period of 3 to 4 years.
Okay, thank you. Paucity of time, we need to move on. It was an excellent talk. We now have Dr. Nivedita Narayan, who's a senior consultant, cornea, refractive and cataract surgery, and she's from Shankar Netralaya, Chennai. And she's going to tell us something so important and so much relevant, step ladder treatment for severe dry eyes. On to you, Dr. Nivedita.
Is my slide visible?
No, your slide is not visible. You have opened your presentation beforehand, no?
Yes.
Mrs. Sunil, could you help her?
Doctor, can you please stop sharing? First open your presentation, then share.
No, it is open.
I'm just stopping your presentation.
Yeah.
Yeah, it's okay now. Yeah. Please.
Yeah.
Please play.
Please play.
It's visible now, yeah?
Yeah. Perfect.
Okay, fine. So I thank Dr. Chitra and the organizers for giving me this wonderful opportunity. So I'm going to speak on step ladder approach to severe dry eye. So the TFOS due to revised definition says it's a multifactorial disease of the ocular surface with loss of homeostasis of tear film accompanied by ocular surface symptoms with tear film instability, hyperosmolarity, inflammation, damage, and neurosensory abnormalities playing a very critical etiological role. So when we see a patient, we start with the triaging questions to rule out the mimicking factors. And if we feel that the patient is suspicious of having a dry eye, we move on to assessing the risk factors. And then when we suspect the patient has dry eye, we put the patient on the diagnostic tests, which includes the screening questionnaire and then the homeostatic markers. At the end of it, the patient is divided into either an evaporative component or aqueous component deficiency or a hybrid variant. Based on the results that we get, the severity and the duration, we classify the patient into different severity and the grades of the dry eye. So the treatment should be tailor-fit to what the patient actually lacks. Is it the lipid layer more over the aqueous or vice versa? How is the epithelium on the surface? Is there an underlying ocular inflammation? So each of these components could be interlinked, but it could be variably affected. And so we need to attend to it. So the treatment basically depends upon the dryness type, severity, extent of damage, and the underlying systemic illness. So the step up actually means by each severity, there is an incremental engagement of the various modalities of treatment based on what the patient is mainly suffering from, aqueous or evaporative, which first and how to combine them. So this is a case of a 51-year-old female who came with mild burning sensation, redness for a period of 3 years on and off. She did say that she had an emotional tearing lack for 1 year. The eyes look little pink, 6/6 vision. So when we pondered on her triaging questions, we found two factors in her, risk factors. One is a dry mouth and a joint ache. She casually mentioned she was diagnosed to have an episcleritis 6 years back, treated once elsewhere, otherwise nothing. So when we put her through the questionnaire, she scored 12. 12 is abnormal, so that's a positive sign. Then she went into the tear osmolarity evaluation. Apparently, it looks normal, both eyes, but the disparity between the two, what do you call the heterodiacity, is more than 8. So this is also a positive sign for us. We put her through the keratograph, which tells us about the non-invasive tear film breakup time. The right eye looks all red. The red is very simple, is abnormal, green is normal, and yellow is borderline. So the red is all abnormal, which means the breakup is earlier. The left eye has green more, so it is apparently normal. When we look at the mammography, it shows areas of dropout. And when we compare it with the normal areas, it is somewhere between less than 1/3 of the surface area. So this comes to a 0 to 1 grade in both the eyes. So meibomian gland sort of okay, but the tear deficient is more pronounced. Looking at the tear meniscus height, we were able to get in the left eye, which is low, but in the right eye, we could not get. These patients may not cooperate. Sometimes we'll have to move on. Apart from this, the test also gives a red score, palpebral height, and the lipid layer interferometry. We did have hydra for some time, so the patient was able to get that test done. It was a short period of time for demo. And this gives a very nice sum up graph where the grid gives like traffic light signals. Again, the green is normal, red is abnormal. So if from the graph, we can make out that the NIBUT is very abnormal, whereas the meibomian gland dysfunction is not so limited. And in the LIPI view, we come to know the lipid length, the lipid layer length, the partial blinks, and the C factor, the correction factor. Based on these things, the lipid layer is sort of moderately involved. And in the mammography, again, we see that the glands are lost, but not so gravely. So that is the standard. Now, when next we move on to the surface staining, here all the surface, the cornea and the conjunctiva is all stained, which means there is a huge area of surface damage. So the patient puncture was tested, they were all patent. Finally, the Schirmer's was done, and which was 3 and 4 very less. Forced fluorescent test showed 0 millimeter at 10 and 20 minutes. So absolutely there is no tear. And at the 30 minutes with the reflex tearing, there was minimum. So is the patient actually tearing or not? We wanted to see. So if you see the video, the area where the gland is, the lacrimal gland, there is some amount of tearing, though it should be much more. So the patient is tearing, but it is not good enough. So the patient was referred to the rheumatologist. Rheumatologist confirmed RA positive, secondary Sjogren, was started on systemic medication. So we diagnosed it as a DUCE 3, severe dry eye with secondary Sjogren's. So based on what the patient required, we started with tear supplements to control the inflammation. Cyclosporin was also started. And once the inflammation had subsided, we put the patient on punctal plugs, all 4 punctae. The patient was found to be very comfortable and then went on to do a permanent cautery. Patient was improving, inflammation completely subsided in a couple of months. And then we moved on to the evaporative component of hot fermentation and lid massage. In the post-operative period, the staining is much less, patient symptomatically better, the pink eye is sort of reducing. The tests are also showing that the non-invasive BUT is improved and the lipid layer scores are also better. The interferometry also shows that the post-operative lipid layer coating is better than the preoperative gray area. Here you have some color fringes. So that was a step up. Now we deal with the next patient who came to us with a totally perforated cornea and came in an emergency. We had to take him directly to the OR and do a tectonic PK, the lens extruded on the table. This was a young male, 50 plus years. In the post-operative period, when we asked the patient about the previous history, he came up with a report from the other clinic where he had a perforation and there was a tectonic graft. We then looked at the other eye. Patient had dry eyes. So then retrospectively, we referred him to the rheumatologist. Rheumatologist medication started. The graft failed, but it was stable. After a couple of months, the patient stopped medication and then came back again with a melt. We had to redo the graft, which is kicking well, almost now 6 months plus. The patient is on continued rheumatological medication along with the eye topicals that we gave him. So this is actually a step down, so based on what the patient actually needed. So dry eye is a very strange condition. It can present in various groups, and there is going to be a pandemic of or epidemic of dry eye. So we should all know that it can present in different ways, and so accordingly it needs to be managed. I thank for the patient listening and the opportunity.
Thanks, Nivedita. That was a wonderful talk. I have a question for the panel. What is the actual duration of using doxycycline in patient with meibomian gland disease? How long? Anyone? Very simple question. Why everybody is tired? Dr. Himanshu?
I really don't think there's any particular duration which is like there's no scientific evidence of the duration.
Stop sharing, Dr. Nivedita. Stop sharing. You can press that button.
Okay, okay.
Yeah, yeah. And what is the role? There are some studies which say that punctal plugs can be used even if the eye is still inflamed.
Yeah, sure. Just to touch up about the doxycycline part of it. So it depends on the etiological factor also, that for which condition you have given the doxycycline. Many of those cases which are like ocular rosacea kind of pictures, those are cases where they do benefit for a little long-term duration, and shorter courses do not help because the disease process lasts much longer. Those acute infections which are more treatable with a shorter course of treatment can be given for like blepharitis, which are treated with a shorter course of treatment, as well as the topical treatment. You can give shorter course of steroid. Different people have different regimes. Some people give twice a day for 15 days, and some people give for a month times twice a day. I really don't think there is any evidence which can possibly prove it or disprove it.
Yes, Dr. Sunita, you would want to add something? Dr. Sunita? Yeah. Could you
Sunita,
yeah. So I agree with Dr. Himanshu. There's no specific protocol, but so far as what I spoke to, some of the dermatologists for treatment of rosacea, especially those kind of cases, they really need a long term.
True,
So,
very true.
as you said, like twice a day for 3 weeks time, and thereafter once daily for 3 months is the usual protocol from the time when they had very severe and active blepharitis and meibomitis. So that is something which is followed, and sometimes these patients also benefit with flaxseed oil, incorporation of omega-3 fatty acids in their diet, and also capsules. So there's some bit of, I don't know, there's doubtful.
In fact, that's very interesting, Sunita. Today only in OPD, there were 2 cases. One of my colleague called up and referred to me that 2 of her post-LASIK patients who were on omega-3 had severe acne and those things post-omega-3. And I didn't have idea. She asked me, I said, I don't have any idea. So very interesting thing. I'm really not sure where to draw the line there.
Yeah. And what is the role of punctum plugs? Would you ever use it in an acutely inflamed eye?
Yes, personally, it's very so. Again, we don't have any answer to that. We all like to believe intuitively that inflamed eye, when we keep the tears for longer time, inflamed tears are on the surface and they're going to damage the surface, which is very simplistic thinking, because dry is very complex. As Nivedita was saying, that it's very complex disease. It's not as simple disease. And then we do know that there are publications which showed us that even Kluckfelter's group showed that in acutely inflamed eye also, well, it still works. So possibly we would love to reduce the inflammation. There is no harm if we are able to wait for it to reduce a little bit. But if at all we go ahead, it may still work. The question is that how soon you have to do. I mean, there may be logistic issue. Person may not be able to come to you after particular duration which you want, say like probably 3 weeks or 1 month or so. And you may have to put the plug a little earlier, but sometimes there may be a patient who is sort of nearby or from your city and is able to come back after your initial topical treatment, and you might want to wait there.
Yeah, right. Anything, any important point which you got left out, the whole session, which want to be covered before we say bye-bye, let's all go for dinner?
Chitra, you have collected so many topics and such beautiful speakers and such amazing panelists. How can you leave behind anything?
Yeah, it was truly a very informative, and our speakers really fantastic.
We learned more than wonderful collection of topics.
It was truly a very wonderful meeting with the expert panel chipping in so effectively, and each speaker making us feel that there were hardly any questions, but we still managed to have some amount of panel discussion. And I really need
all talks were complete. There were hardly any questions.
Very
amazing it was, and I truly have to thank my expert panel and every single speaker. And of course, hats off to you, Himanshu. Like having Himanshu as my moderator was like having so much of Revital tablets I'd eaten at one gulp. That was the kind of energy I had when I came to this session this evening. And of course, we have to also thank my ARC team, although they are not there, but they're always behind me and always supportive and very encouraging. I need to thank the AIOS admin headed by Kripal for the SMSs and every kind of help they give. And of course, thanks to Sai and Numerotech for the emails which come to all of you. And most importantly, I think we owe our thanks to our delegates. And I'm sure at the end of it, I would badger Sunil to tell me, Mr. Sunil, how many attended. And recently I've seen the attendance has actually gone up even more. And whenever I go for some of these meetings, I have so many telling that don't give up on these webinars, because you're able to sit at home and imagine the galaxy of speakers and expert panel we learned from today. And thanks to all our delegates. Thank you, one and all. And of course, thanks a lot to Entold for sponsoring all our webinars. So thank you very much, everybody. Thank you.
Thank you, Chitra. Thank you.
Thanks. It was nice that you joined, Amrita. Thanks a lot. Thank you, everybody. Thank you.
Thank you. Have a nice evening.
Thank you, everybody.